and welcome to the second virtual series on cardio obstetrics organized by the Society of Maternal Fetal Medicine, Mysuru chapter. So now I call upon Dr. Sushma Dev, our president, to welcome the gathering. Dr. Sushma?
Yeah. Very good morning, everyone. Indeed, it's a great pleasure and honor to welcome all the eminent faculties and our delegates who have joined to this our unique virtual learning series organized by our Society of Maternal Fetal Medicine Mysuru chapter. So at our society, we have been constantly endeavoring and conducting a lot of CMEs focused on medical disorders in pregnancy. In this constant efforts is our today's venture on the virtual learning series on the very important disorder, that's the cardiac obstetrics, so which is almost a very important discussions and very important complications for the maternal life and the future. And today's program is our second series of virtual learning series on cardiac obstetrics, which we are focusing on the late complications in cardiac patients in pregnancy. And it is our honor that we have very eminent speakers all across from South India. And I welcome our chief guest, Dr. Sampath Kumari ma'am, and our guest of honor, Dr. Vidya Tobe ma'am. And also in our faculty, we have eminent cardiologist, Dr. Satish, Dr. Nagendra, and we have our intensivist, Dr. Lakshmikant from Mysuru. And we have team of obstetricians from JIPMA, Dr. Lata Chaturvedula, Dr. Shashireka, and our Dr. Gitanjali, Shashireka, and Sunita Kalluri. And of course, we have the huge audience, our own faculties who are joining us to enlighten our knowledge and let us stream across today's program. To start the program, we'll start with the formal inauguration of lighting the lamp. It's our time to welcome our chief guest of today, Dr. Sampath Kumari. Due to our emergency travel to Kolkata, in the current time, she's traveling by air, but still, Madam has sent a message to us through our video. So the Madam is very eminent personality, the former Vice President of Foxy South Zone in the year 2022, and she's the former Professor and Head of the Department of Shri Muthukumaran Medical College, and also Senate member of Tamil Nadu MGR University and the National Coordinator of Jogi Journals and Founder Secretary of TNFOG. And she has a huge list of our awards and into her CV. And we are really glad that Madam has accepted to be our chief guest, and thankful that Ma'am has sent a message to us in a video recording. And of course, Madam will be shortly joining us in the middle of our webinar. Hema, can you please play the video of message?
Good morning to all. I thank Dr. Sushma for inviting me as a chief guest for this wonderful and important CME, the cardio obstetrics. This CME have been organized by the Mysuru team, Dr. Sushma and Dr. Hema Priya, with the fetal medicine team, Dr. Prakash Mehta and Dr. Revati. The incidence of heart disease complicating pregnancy is only 1 to 4%, but the mortality being 26% of all pregnancy, including the peripartum cardiomyopathy. You have taken the important topics such as late complications in pregnancy, minimally invasive procedures, fluid therapy and anemia by the well-renowned speakers. And you have the panel which deals with the labor in the cardiac complicating pregnancy. I think the delegates will have the wonderful take-home messages. But though we don't have the echocardiography as the universal screening, it is better to have the echo for all patients in pregnancy, such that we can reduce the mortality and identify the complications at the earliest stages. Thank you. Once again, I wish all the best for the success of the webinar. Thank you.
We thank Sampath Kumari ma'am even in absentia. We are glad that madam has sent the words of wisdom and encouraging words to us. And it's again our honor to welcome our own Vidya Tobi ma'am from Karnataka State Obstetrician Society. The madam is the immediate past president of Kasoga 2023, the professor and former head of the Department of OBG, Alamein Medical College, Vijaypur. She is the state advisory of PCPNDT Board of Karnataka. She was the chairperson for the Food, Drug and Medico Surgical Equipment Committee of FOXI, the very active personality in Karnataka and leading most of us, and also the actively working in the FOXI for our growth. And the Best Committee Award has won by the madam. She's ICOG Governing Council member, FOXI Champion Award in 2019, and also the Jogi Corresponding Editor. She was the organizing chairperson for the Kasauga in the previous years, and she has n number of publications to her credit. And we are very glad that madam has accepted to be our guest of honor, and we request madam to render our address. Over to you, madam.
Yeah. Thank you, Dr. Sushma. It is indeed a pleasure to be with you all. I hope I am audible to all of you. And it is really a great webinar, I must say, organized by the Society of Maternal and Fetal Medicine of Mysuru chapter, I must say, and as well as the Department of OBG, JSS Medical College, and other institutions who have joined. I think the cardiac diseases are on increase, and we should be aware that most of us we are not screening the woman for these various heart diseases. Now, hypertensive disorders in pregnancy is a major cause now for the maternal mortality and morbidity, apart from other medical disorders like anemia and gestational diabetes. And many times we find that we don't follow these patients, especially the hypertensive disorders, in the postpartum period. And then we have noticed that these women, they'll end up with various complications. Now, these cardio obstetrics, whatever, the first part also, it was very interesting. And I think it is available on YouTube. If you have missed that, please go through. That was also excellent one. I had attended that. And I must congratulate. This is the second part, which has got various eminent invited faculties, I must say, which has got cardiologist, interventional cardiologist, and then critical care also they have joined, along with obstetrics. And I feel that whenever we are managing any cardiac case, it should be a multidisciplinary approach. Then we need various interventions also. The peripartum cardiomyopathy is another important disease, which we many times at periphery they fail to recognize, and many mortality and morbidity we see when it is not recognized and treated properly. So let us learn further today about something more about it. And I'm very happy about the fluid management in labor and anemia correction in cardiac disease. These are the two important topics which a common obstetrician must know, that sometimes the patient has got cardiac disease and patient comes with, if she lands up in PPH, we go on infusing, and then heart failure occurs, and then we have to treat that. Okay, and there is an interesting panel discussion by Dr. Sashi Rekha, that is management of labor and postpartum in cardiac disease. So I'm very eager to listen to all of them, and again I heartily congratulate the team as well as the faculty. and the delegates will surely enjoy this important webinar. Thank you very much, Sushma.
Thank you so much, ma'am, for your inspirational words. And of course, our efforts from our society was to involve multidisciplinary. That's a different speciality, because as obstetricians, in most of our obstetric scenarios, we always need the combined effort, help of other specialties, the medicines, the intensivist, and of course, the anesthesia and cardiologist. So we often have a formal discussions in most of cases. Through this virtual learning series, we wanted to upskill ourselves so that we will be more into the practical discussions, and the clinical knowledge of cardiac management will, of course, will improve our clinical management so that we can move towards reducing the maternal mortality in our future practices. And especially we thank all the cardiologists who have joined us and are sharing their immense knowledge, especially in caring these women with cardiac diseases. For the further discussion on the program, over to you, Hemapriya, to start the discussions. Dr. Hema, you are muted. Hemapriya, you are muted.
Thank you, Sushma, and thank you, Vidyathabi ma'am, for your encouraging words. Now let us move ahead with the scientific program. I will first introduce our chairpersons. Dr. Lata Chaturvedala. Madam is Professor of OBGYN in JIPMER, Pondicherry, and she is also the President of the OBG Society of Pondicherry. And ma'am has a FICOG as well as an MBA in Hospital Administration. And she has won various awards and has various funded projects to her name. Welcome, ma'am. And our next chairperson is Dr. Shashireka. Madam is a senior consultant interventional cardiologist at Manipal Hospital, Mysuru, and she has a special interest in cardio-obstetrics, ECMO, and cardiac failure. Welcome, Dr. Shashireka. And now I request Dr. Lata Chaturvedala to introduce our first speaker, Dr. Satish Parasuraman.
Good morning, everyone. Thank you, Sushma and Hemapriya, for inviting me. Though I'm slowly moving out of obstetrics, yeah, and it's cardiac disease has always been, we face every day to day. Still, though we say congenital heart disease is quite high, we still see a lot of rheumatic heart disease. It's not totally gone away. So we have a varied, varied variety of cases which we come across during pregnancy. I think we've always been listening from obstetrics point of view how to manage these pregnancies. I think it's high time we should listen to what cardiologists have to say, and it's always better to have this kind of multidisciplinary discussion so that we all come to a common consensus of how to manage. So for this, the first speaker, I'm glad to introduce Dr. Satish Parasuraman. I can see so many degrees. He's a structural and interventional cardiologist at Apollo Specialty Hospital, Madurai. And he's done coronary intervention fellowship in UK and has also done safe and effective complex PCI operator and has presented in American Heart Association. I think, and of course, most important, his holds a research in PhD in heart failure from University in East Anglia. And over to you for all those achievements you've had, Dr. Satish Parasuraman. He's going to talk on long-term late pregnancy complications with respect to cardiac disease. Dr. Satish?
Yes, thank you very much. Thank you very much for that kind of introduction, actually. Thank you so much. I'm presenting from Kodaikanal, actually. We came on holidays for a couple of days. Thank you very much for the Society of Maternal Fetal Medicine and the Department of Obstetrics and Gynecology at JSS Medical College and Hospital. Thank you, Dr. Hemapriya, for inviting me to talk, and Dr. Sushma Dev and Dr. Lata for the kind introduction. I'll start with this slide. This was a WHO data on maternal mortality during pregnancy worldwide. The purple ones are the ones with low maternal mortality, and the more redder it gets, the higher the mortality. Now, you see India is right in the middle, between 150 to 250 maternal deaths per 100,000 pregnancies, worse than some of the neighboring countries like Sri Lanka, Indonesia, China, Mongolia, and Iran and Iraq. Now, the major cause of maternal death in the Western population is cardiac disease, while in emerging countries like India and African countries is anemia, infection, bleeding, and eclampsia. Although you will all agree that the landscape is changing, and we are going to face more of patients with heart disease, patients with congenital heart disease at a younger age, reach just to reach pregnancy, and also more older patients getting pregnant, and also with comorbidities, with obesity, with hypertension and diabetes. We are bound to see more of coronary artery disease, heart failure, etc. Now, this looks a complicated slide, but it's not. It's a study which looked at the index event is pregnancy, and looked at how the patients with heart disease fared over the next 20 years when compared to patients without heart disease. And you can see that they had a very high risk of heart failure several years after delivery, atrial fibrillation on the top right-hand side of your panel. Need for therapeutic cardiac procedures also very high. You know, the one and the blue worm is the patients with the heart disease, while the red flat one at the bottom is the patients without heart disease. The occurrence of diabetes and hypertension years after pregnancy is also high in the bottom right-hand panel. It's quite obvious that this will happen. I think we all know that this will happen because they have a heart disease. But this tells you that we have to, it's not just about pregnancy, but also we have to follow these patients through several years after pregnancy, because they develop multiple complications and they need procedures several years down the line. The best data we have from the Indian setup is the Madras Medical College Pregnancy Registry, published last year in 2023. It studied about 150,000 pregnancies, and just less than 1% of those pregnant ladies had heart diseases. About 1,150 patients out of 150,000 ladies with pregnancies had heart disease. And I know it looks busy, but I just want to focus on the right-hand side. So the maternal mortality in patients with heart disease is about 2%, and the fetal loss is about 9%. So this will help you to inform your patients when they counsel you before pregnancy, or even during pregnancy. So the predictors of maternal and fetal events are pretty much the same. Essentially, patients with mild form of, say, congenital heart disease or valvular heart disease or heart failure had a lower risk. You need to remember that heart failure and pulmonary hypertension are the final common events in most heart diseases, like whether it be a congenital heart disease or whether it be a rheumatic valvular heart disease or ischemic heart disease. The common endpoint is pulmonary hypertension and heart failure. And when some patients have advanced heart failure and pulmonary hypertension, they fare worse. But when patients have a milder form of valve disease or corrected congenital heart disease, they do well. So the predictors of adverse maternal events were left ventricular dysfunction, pulmonary hypertension, severe form of valve disease, prosthetic heart valves, especially mechanical heart valves. They were at higher risk of maternal complications. The first diagnosis of heart disease made during pregnancy, for some reason or the other, is also contributes to high maternal events. So as I mentioned earlier, Maternal deaths occurred in approximately 2% of those ladies with heart disease during pregnancy. Maternal cardiac events occurred in 15%. Again, it's useful for you to inform your patients. So maternal complications occurred in 15%, made by arrhythmia, heart failure, need for interventional procedures occurred in about 15% of patients with heart disease during pregnancy. Most of these complications were heart failure that occurred in 10% of patients. Again, the predictors of adverse fetal events were pretty much the same. Severe valve disease, severe heart failure, severe pulmonary hypertension, severe congenital heart disease, again, pretty much the same. As we mentioned earlier, the fetal loss occurred in 9% of the 8.8% of the patients. Adverse fetal events like preterm babies, underweight babies, and fetal loss occurred in 33.7% of patients. About 20%, that's as we discussed earlier, 2% of maternal deaths occurred in this registry. That is 20 patients out of 1,150 patients. And 5 of these deaths occurred antenatally, and 75% of the deaths occurred on or after delivery, up to 6 weeks after delivery. If you see the lines in red, you can see the deaths started occurring from week 12 until week 29. There is a way to categorize people into low and high risk patients. That is the patients with heart disease. How do you classify them as a low and high risk group? Although it looks like a busy slide, essentially the summary is those patients with milder form of valve disease, milder form of heart failure, asymptomatic valve disease, corrected congenital heart disease like atrial septal defect. All those go to a WHO class 1 and 2 in the top, and you can conduct delivery for these patients in the local hospital, and a routine follow-up or just a little bit more frequent follow-up might be enough antenatally. While class 2 to 3 in the middle have a very high risk. They have moderate to severe left ventricular impairment, moderate to severe pulmonary hypertension. They have uncorrected congenital heart diseases that require the expert care and delivery at a higher center. Pregnancy is not recommended in the severe forms of the same diseases like severe symptomatic mitral valve stenosis, etc. This is a ROPAC registry showing that how patients with WHO class 3, 3 and 4 types of congenital heart disease do badly during pregnancy, while type 1 and 2 do well. Now, the hemodynamic changes during pregnancy, we all know that the plasma volume and the cardiac output increases during pregnancy by about 50%. Most of these changes, we need to remember, have occurred by the end of the first trimester. Now, going back to the impact registry, you would see the first death occurred by 12 weeks. That's because most of the changes to the plasma volume and cardiac output have occurred by week 12. The initial rise in the stroke volume, initial rise in cardiac output is contributed by the stroke volume in early pregnancy and later by increase in heart rate. But also, there is also a hypercoagulable state during pregnancy with increased risk of thromboembolism, increased activity of liver enzymes, glomerular filtration rate, plasma volume, and the decreased serum albumin all contribute to changes in functioning, the pharmacokinetics of many drugs, uterine contractions, and even simple supine positioning of the patients can contribute to heart failure during delivery. Hemorrhage, anesthesia, infections all pose additional stress to the heart. Heart failure, there is a twin peak kind of presentation during pregnancy. Incidence of heart failure increases between 20 to 30 weeks during pregnancy, but again, just after delivery to up to 6 weeks after delivery. Peripartum cardiomyopathy has a high mortality rate of 6%. Less than half these patients recover to full cardiac function. Neonatal death occurs in about 5% of the patients. Atrial septal defect, we will all face atrial septal defect patients because that's one of the most common congenital heart diseases around. If the patients are treated earlier and they had previous percutaneous or surgical closure, then the risk is very low. They belong to WHO class 1. In unrepaired ASDs, especially if they had if they have hemodynamic effects like right heart failure, the complications rates are high. There is something called paradoxical embolus. Some of you might be aware of. Normally, even in uncorrected atrial septal defect, when patients reach pregnancy, they will have shunts from the left to right, left atrium to right atrium, because the pressure of the left atrium is high. But on some occasions, the blood flow can be from the right atrium to the left atrium. And if there is a DVT, for example, they can have a paradoxical embolus to the left side circulation, causing a stroke or a heart attack. Congenital heart disease affect the mothers because patients have a long-standing high ventricular pressure and volume overload. This contributes to ventricular hypertrophy, scarring. There is a pre-existing ventricular dysfunction, and the heart may not be able to tolerate the increased hemodynamic stress of pregnancy. The hypertrophy and scarring I mentioned earlier contribute to arrhythmias during pregnancy. Aortic dissection, we would all have faced aortic dissection at some point in our lives, pretty nasty experience. And usually we are taught these patients will be pretty sick and unwell, but these patients can be pretty, only have mild symptoms, so high index of suspicion is needed. It is a spectrum of diseases. Some patients just have aortic ulceration, some patients have aortic hematoma, and then some patients have frank aortic dissection. Patients with genetic aortopathies like Marfan syndrome, Lewis states, and vascular Ehlers-Danlos have a very high risk of aortic dissection during pregnancy. Patients with type 4 vascular Ehlers-Danlos should be advised not to get pregnant at all. While patients with bicuspid aortic valve and Turner syndrome also do have a higher risk of aortic dissection, but this risk is not as high as Marfan's and Turner syndrome. The number you have to remember is 4 centimeters. So any aortic aorta size of 4 centimeters or more, you need to call for a cardiologist because to assess the entire aorta and to predict the risk of aortic dissection. Because we do echocardiograms in most patients with pregnancy nowadays, please ask your cardiologist or the echocardiographer to mention whether the aortic valve is tricuspid or bicuspid, because in bicuspid aortic valves, they can have a dilated ascending aorta, which may not be clear on echocardiogram, where additional screening might be needed, like a non-contrast magnetic resonance aortography. Mitral stenosis is very common, as Dr. Lata just now mentioned, because we will always, rheumatic heart disease is still around. One of the rare indications to intervention in an asymptomatic patient is patient with a severe mitral stenosis. Percutaneous balloon valvotomy is indicated during pregnancy to reduce maternal and fetal complications. I'm sure Dr. Nagendra Gupti, an expert in structural heart disease worldwide, will go through this shortly. Aortic stenosis in asymptomatic patients. Aortic stenosis is patients with aortic stenosis tolerate pregnancy reasonably well. If there is doubt, we should ask the patient to do an exercise tolerance test to see if they're really asymptomatic. The treatment options, there are three treatment options for these patients. They can undergo percutaneous aortic balloon valvuloplasty, percutaneous TAVI. You might have the recent advance in technology has allowed us to implant a valve percutaneously, also an open heart surgery, but this has to be tailor-made for each patient. Arrhythmias, the most common form of arrhythmias will be atrial fibrillation or supraventricular tachycardia. Fortunately, if the patient is hemodynamically compromised, we should treat them routinely with cardioversion. Cardioversion does not seem to affect the fetal blood flow, fetal arrhythmias, and does not induce labor, so it's pretty safe during pregnancy. and should be conducted if necessary. Drugs like flecainide, beta blockers, calcium channel blockers, digoxin can be used to treat atrial fibrillation and re-entry tachycardias. Novel anticoagulants like apixaban, dabigatran, rivaroxaban are not allowed during pregnancy. Catheter ablation is rarely performed during pregnancy, for example, to map and treat arrhythmias. But um, if the if needed, it should be postponed to the second trimester. As we saw earlier in the impact registry, one of the high risk features that can cause maternal and fetal adverse events is mechanical valve thrombosis. One of the main reasons is pregnant ladies stop warfarin anticoagulation as soon as they know that they are pregnant to reduce the teratogenic effects of their babies. Further, we can complications can occur when the doctor switches the warfarin to low molecular weight heparin and vice versa during pregnancy. So we should all have a pretty standard protocol as to how to deal with mechanical heart valves, how to change from one form of anticoagulation to another, and this should be strictly followed. Generally, low molecular weight heparin is advised in first and the last trimester, while warfarin is safer during the second trimester. Pulmonary hypertension, as I mentioned earlier, is the end result of most heart diseases, and moderate to severe pulmonary hypertension poses huge risk to both babies and the mother. Patients with increased pulmonary vascular resistance, which means they have permanent changes to their pulmonary pressures due to pre-existing heart diseases, pregnancy is not recommended. Some of the treatments like bosantan are contraindicated during pregnancy, while some of the treatments like phosphodiesterase inhibitors are accepted during pregnancy. If the mother has a low saturations of less than 90%, there is a very high fetal and maternal risk. The fetal risk is approximately 90%, and the maternal risk is 30%. So if you see somebody in the antenatal clinic with oxygen saturations less than 90% with pulmonary hypertension, you should counsel them against pregnancy, because, as I said earlier, the fetal risk is 90% and the maternal risk is 30%. Venous thromboembolism, we always face this in our routine practice. Patients come with leg swelling or breathlessness, and we debate about how to go about investigating and treating them for either deep vein thrombosis or pulmonary embolisms. D-dimer is not very helpful during pregnancy because most women have elevated D-dimer during pregnancy, but at the same time, negative D-dimer does not rule out deep vein thrombosis or pulmonary embolism in these patients. A high index of suspicion is needed. Most of these patients have left leg DVT because of compression of the left iliac vein by the left iliac artery, by the gravid uterus, and left leg involvement, left calf size of more than 2 centimeters compared to the right calf size, and positive ultrasound, Doppler ultrasounds can help diagnosing DVT. If needed, we can do a low-dose CT pulmonary angiography to look for a pulmonary embolism as well. Myocardial infarction. Myocardial infarction is rare during pregnancy, but is 4 times more common than in non-pregnant women. About half of these cases are due to spontaneous coronary artery dissection because of the increased hemodynamic stress, shear stress on the coronary blood vessels. Coronary intervention is indicated in high-risk myocardial infarctions, patients with ongoing chest pain, etc. We will try to avoid intracoronary intervention like stenting in low-risk myocardial infarction patients. Thrombolytic drugs do not cross placenta, but increase the maternal bleeding risk. Drugs are a problem during pregnancy. Aspirin is safe, but clopidogrel and statins are not advised. Infective endocarditis carries a very high maternal mortality and fetal mortality. Patients with rheumatic heart disease, bicuspid aortic valve patients, congenital heart disease patients and complex surgical procedures before should receive antibiotic prophylaxis as they carry a very high risk. Normally, vaginal deliveries are advised in most patients with congenital heart disease, apart from those with a very dilated aorta, like in Marfan syndrome, critically ill patients with aortic stenosis, pulmonary hypertension, and anticoagulated mothers, just to so we can take control of their anticoagulation during delivery. This is a cardiopulmonary exercise test that we did in a lady who came for in vitro fertilization. She's a 38-year-old lady with infiltrative heart disease involving the left and right ventricles with severe LV impairment, and also she has a complex pacemaker to help support her heart. And here, by this test, we can say that this patient is pretty limited. Her exercise capacity is pretty limited, although the saturations are good. Saturations 100% during exercise and rest. She has other features indicating very high pulmonary pressures and very poor chronotropic response. That's a poor heart rate response to exercise. So her resting heart rate was about 50. The peak exercise heart rate was 118. At the age of 38, you would expect the peak exercise heart rate to be about 160 or 170. So poor chronotropic response to exercise indicates higher risk. So we advise the patient not to undergo in vitro fertilization, especially as it carries the risk of ovarian hyperstimulation, which leads to marked fluid shifts and even higher risk of thrombosis. So we advise the patient not to undergo pregnancy. Exercise tests can be also performed during pregnancy safely, if necessary, to assess the risks. So finally, I would just summarize this by saying that a good patient history to see whether they had a cardiac events prior to pregnancy, what is their functional status. A simple way of assessing functional status is that whether the patient can climb 2 flights of stairs without getting breathless, any presence of any mechanical heart valves, anticoagulation, aortic diseases, coronary artery disease. So these are all in the history. Physical examination, please check their saturations. If their saturations are less than 90%, there is a very high maternal and fetal risk. Imaging echocardiogram to assess the left ventricular function, right ventricular function, and pulmonary hypertension. Again, late first antenatal visit poses a higher risk in these patients with heart disease during pregnancy. And then in multidisciplinary team involvement, as previously mentioned by Dr. Lata and team. Thank you very much. And any questions, please?
Yeah, thank you, Dr. Satish. I just have 1 or 2 questions with you. Actually, Tamil Nadu has started screening all the women routinely for heart disease, and maybe we are coming across some patients who have the lesion but do very well. What is your take on it? Should we screen all women? I mean, this is mainly for medical legal purpose, but they are doing it at a primary health center level, not even in the district or main hospitals. What's your take on it?
I think it's a good initiative because we can find a lot more patients with heart disease, but the report has to be comprehensive. As I said, whether there is a ventricular impairment, right? It's just ejection fraction is just only one component of heart function. Looking at the right ventricle, reporting any bicuspid valves is not mentioned in most reports because these patients have aortopathies. So I think it's just one part of I guess it's easy for the administrators, the lawmakers to make a policy like, okay, everyone gets echocardiogram. But as a clinicians, I think, as I said, a good clinical history documentation, because the status of the patient can do so much. That may clears up most of the echo can add to your assessment, but echo can miss things as well. Echo is not like you find everything. Patients have a lot of patients with normal aorta size can have aortic dissection. So it's not like you find every aortic dissection by echocardiogram. You prevent the pulmonary embolism or coronary artery dissection by echocardiogram. It's a useful initiative. It's a global thing. I know I think it puts a huge stress on the system, but I think as far as clinicians are concerned, I think we can select our patients by good history, functional status, any previous.
Most important, I feel, is something people are missing is on examination. when they come to the obstetrics, people forget to do a systematic examination. That's where we end up in problems. That is something very, very important. And Dr. Kavita, just 1 minute. One more thing about antibiotic prophylaxis. Though WHO recommends only for class 3 and class 4 now, what is your take? We still give at least 1 dose. Earlier it was like 2-3 doses. Now we give 1 dose of prophylactic antibiotics.
I think I'm pretty liberal in prophylactic antibiotics, to be honest. And 1 dose I think is pretty much enough. During labor, I'm not sure, but during any interventions prior to labor, I think 1 dose is mandatory. And if we give 1 dose for any patients with, I think high risk ones are those with any foreign objects like baffles, etc. But I think we should be pretty liberal in our group of patients. Anyone with previous surgeries, anyone with previous congenital heart disease, underpad valves, bicuspid valves. Especially with one question will be previous endocarditis. That will be a key thing to note down because those will be a very high risk.
Thank you, Dr. Satish, for a very elaborate presentation on all the problems of cardiac disease in pregnancy. Should we move on to the next question? Dr. Kavita had one question, I think. She had to say something.
So getting a 2D echocardiography is obviously not feasible in our country across so many places. But I think complete history and thorough physical examination involving all your 4 limbs, pulse, then pre-pregnancy maybe an X-ray to see the size of aorta, to some guess of aorta, then as this saturation level doctor mentioned. So I think when pregnant lady comes to a gynecologist, so the examination should not confine only to the pregnancy part of it. Some doctor has to at least can examine the patient thoroughly from head to toe. So that will also pick up because we have seen our gynecologists, even if they hear a little murmur, they will call us. And since obviously murmur is such a non-specific thing, but then at least we proceed with the echocardiography. And no valvular lesion of significant stenosis or regurgitation will present without any murmur which can be heard. So general physical examination and systemic examination is very, very important. That can be emphasized at every center, I guess.
As rightly said, in most of the situation, even at this scenario, we cannot generalize on the routine indication of echo. But still, whenever we have a feasibility or facility in our institution base, it's a good opportunity that we do echo in every pregnant woman if the woman accepts and you have the opportunity to do it. Because this is an opportunity in pregnancy to screen most of the diseases, especially medical disorders. So, and we can do justice to the woman. But we cannot generalize this as of now.
Hi. We at Gopal Gowda Hospital are right now emphasizing that all the patients undergo echo, especially all the pregnant women. And I agree that it's not feasible all the time, but if it's feasible, I think it's a good idea to get an echo done. And another thing is, I just would ask the faculty if the scoring system, that is like the CARPREC scoring system, are being used for cardio-obstetric cases. Is it being used routinely? And I have always also appreciated the efforts from JIPMA. They had a specific Davy score for valvular heart disease. And these scoring systems, to an extent, can help us risk stratifying the patients. And one more thing I would add to the discussion is we are eagerly awaiting the results of the NPAC study. It's a study initiated by the Department of Cardiology and IOG, so which is studying the outcomes specifically for Indian women. So, so these are a few comments that I would like to make. Thank you.
Thank you. We'll move on to the next speaker. I'm happy to introduce Dr. Nagendra Bhupati, who is a professor of cardiology and senior consultant interventional cardiologist at Srihar, Chennai. He has done his fellowship in interventional cardiology and structural heart disease interventions from School of Medicine at Mount Sinai, New York. He is obviously a DM in cardiology from AIMS, Delhi, and is an adjunct faculty of IITs. It's nice to have someone who's collaborating with IITs. Recipient of the Professor P.P. Basu Award for Original Research and is also an ambassador to Europe PCR. authored many chapters in textbooks and associate editor of Tannen's textbook of cardiology. He will be talking about minimal invasive surgeries. We have been talking about minimal invasive surgeries in other fields. Yes, we've also switched over. I remember when we were residents, commissurotomy, it was all open with big scars on the chest and all. Now it's all endoscopic, and I think it will be a good talk to hear from Dr. Nagendra. Over to you, Dr. Nagendra. You're muted, Dr. Nagendra.
Thank you for the kind introduction, ma'am. Is my slide visible?
Yeah.
Is the slide, sir? Okay, thank you. Thank you, Dr. Hema, for this opportunity. After a terrific lecture by Dr. Satish Kumar Parasuraman, who was supposed to, we three are batchmates from Madras Medical College. So Satish Kumar Parasuraman went to UK, and there's a competition between me and him. Whenever we are good buddies, actually. So after his particular lecture, it will be difficult for me to deliver a lecture of that intensity. However, I will try to give some amount of decent information. So I will be discussing on cardiovascular system and pregnancy, pre-conceptional counseling, risk stratification, cardio-obstetric team. I'll be rushing through them because Dr. Satish has already discussed in detail, and what exactly happens during interventions. So when to intervene some of these patients, and we'll conclude with a simple case example. We all know that patient with cardiovascular disease, when the patient goes for pregnancy, is a significant amount of stress that the heart encounters. So we need to identify such patients before they actually go into pregnancy, then treat them using appropriate therapies before the pregnancy itself. So acute intervention during pregnancy, however, has significant impact on both maternal and fetal mortality. That is the goal is to identify the patients before pregnancy and treat them well. So we all know changes that happens during pregnancy. At the end of, if you look at the cardiac output, it gradually increases. Blood pressure remains down initially, later on goes up. Heart rate consistently goes higher. Systemic vascular resistance goes down. And during early postmortem and late postmortem, none of these parameters change significantly. However, during early postmortem, blood pressure goes down, and elevated heart rate goes down. Majority of patients during pregnancy have BP of 80, 90 and all. So that's predominantly because of systemic resistance. So alteration affects the pregnancy lesion significantly. The increased cardiac output leads to increased gradient and increased severity of most of the lesions in the heart. And pregnancy, as we all know, it's a hypercoagulable state. They are prone for venous thromboembolism, and there's going to be a hormonal shift, and that can relate to some vascular pathology, including dissection, aneurysm, and spontaneous coronary dissection. So the cardio-obstetric team the mandatory is going to have an obstetrician. However, it's essential to have a cardiologist with an interest in obstetrics. Pre-pregnancy counseling is pretty essential. They have to be monitored in a center where essential cardiac procedures could be done, and such patients can be taken care post-operatively. And those patients should have a OG team where high-risk delivery can be conducted. Pre-conceptual counseling, in general, identify the seriousness of the disease and treat it before they go into pregnancy. That is the most important thing, because though the outcome is not that bad during pregnancy, it definitely at least 3 to 4 times higher as compared to a non-pregnant patient, most of the cardiac procedures. So the patient's risk needs to be assessed by taking a simple electrocardiogram, echocardiogram. If it is available, NT-proBNP, and if the patient's pre-pregnancy, an exercise stress test could be performed. If the stress test is going to be, if they could achieve more than 80% of the predicted heart rate, then most likely they're going to tolerate the pregnancy well. This has been discussed by Dr. Satish extensively, so I will not be going through it. From interventional point of view, I'm going to talk for the cardiac surgeon also. There are some procedures which cannot be done percutaneously. A pregnant patient, we should have a cardiac specialist who's good in imaging, interventionist, a cardiac surgeon, anesthesiologist, physician, and in case during peri-procedure the patient delivers, a good neonatal team should be available to take care of the neonate if the patient is going to have labor after the procedure. All these things are very essential. First and foremost thing in pregnancy is salvaging the mother. I'm not belittling the baby. However, salvaging the mother is the most important thing. So ALARA is the concept that is being utilized in all radiation related procedures, that is as slow as reasonably achievable. Thereby saying that we should not compromise on the technique, or it should not compromise that we are using less radiation and the information obtained by the technique is less, so that we cannot do a procedure. However, we should use techniques in such a way that the radiation exposure given to the patient should be quite low, but we should come out of the procedure very well. In general, first trimester is the most important thing that affects organogenesis. Highest is before 6 to 8 weeks. So defer intervention whenever feasible during first trimester. Absolutely no. And use as low as reasonably achievable. ALARA. If you lose most of the cardiac, the 5 milligray actually, average radiation is 3 to 5 milligray, 3 to 20 milligray. Most of the interventions we could easily finish it kind of less than 1 gray, not milligray. So we should try to, whenever there's going to be a higher the gray, higher the radiation related side effects, and lower the gestational age, higher the radiation related side effects. In general, if the radiation is going to be less than 50 milligray, less than 50 milligray is quite almost impossible to do a cardiac procedure. I would definitely need at least 0.5, I would say 0.5 gray or 0.25 gray. So we most likely fall into this category. None of the cardiac procedures can be done with 50 to 100 milligray if it is going to be interventional one. So in general, as the gestation goes higher and higher, the side effects because of radiation is going to be lower and lower. How we can reduce the radiation is very essential. We swap from radiation to ultrasonography. Ultrasonography is quite safe. We've got large data to say that it almost does nothing to the fetus. So place the source. Whenever radiation is quite essential, we keep the source, that is the image intensifier and the C-arm and the radiation emitter, to as close to the patient as possible. We collimate the X-ray table very well so that only required portion gets irradiated. We also cover the abdomen of the patient with a lead shield, sometimes 2 lead shields, encircle the abdomen with 2 lead shields, so that we reduce radiation scattered from the patient chest to the abdomen. This doesn't make the abdomen immune, because some of the radiation can go through the chest, enter into the abdomen, and then exit via the butt. So we use less angulation. Predominantly, we try to do most of the thing using AP projection. The fluoroscopic time will be minimized so that we finish the procedure within 0.25 to 0.5 gray. The frame rate, that is the rate at which the X-ray is emitted from the radiation emitter, will be reduced from 15 frames per second to 3.75 frames per second. And we avoid using cine. Cine is a high radiation, so it goes at 15 frames. We avoid using cine. And such a procedure should always be contemplated by an experienced team who can manage emergency, where CT thoracic surgical backup is available. In general, we avoid femoral, so that we can avoid giving radiation to the femoral site. So measure to minimize fetal issues, reduce the radiation, collimate, abdominal sheathing, try swapping from X-ray to ultrasonography, and use radiation, radial access. How to avoid feed maternal issue? Experienced team, CT backup, low radiation, as such is very useful for all the patients irrespective of pregnancy. And if there is some borderline lesion, use non-hyperemic indices rather than adenosine-based indices, because adenosine crosses placenta and give rise to bradycardia to the patient, fetus. Regarding medications that can be utilized during pregnancy. Heparin is quite safe. Metoprolol tartrate is safer than metoprolol succinate. Verapamil, nitroglycerin are quite safe. A low-dose aspirin is safe. However, provision of clopidogrel or other P2Y12 inhibitors like ticagrelor, prasugrel have shown no adverse animal models, but long-term data is not available. Beware of the dye that is used during the procedure. It crosses placenta and it can or it may give rise to fetal thyroid dysfunction, which has to be addressed once the baby is delivered. And thyroid, in contrast, is not excreted significantly in a breastfeeding mother. So no need to worry about it. Maternal consideration, avoid excessive sedation. Most of the sedatives goes to the placenta and make the baby sleep. And heparin do cross placenta. Ensure that you're giving adequate heparin and then keep the ACT at a decent level. Procedurally, we used to keep between 250 to 300. That's okay. And as mentioned earlier, avoid reduce the radiation to avoid teratogenic effects of the same on the fetus. Let's go to the interventional part. Myocardial infarction, valvular heart disease, coarctation, pulmonary embolism, heart failure, cardiogenic shock. There are 5 situations which are which I have personally encountered in my practice. How exactly should we manage them? A lot of conflicting data are there. Let's go one by one. So I have highlighted the data from different guidelines in different papers when we need to intervene such patients. In general, doing less is more in such patients. And if it has been decided to be done, do it after 28 weeks so that the fetus can be salvaged. Number 2. Number 3, accept that these procedures are done only by experienced operators with CT surgery backup. Hence, you should not have any ego that you want to handle the patient yourself. You should be ready to refer such patients to expertise which are available elsewhere, and be humble to get an expert operator also to do the procedure, because we are not dealing with the mother alone. We are dealing with a small unborn baby who has to also be salvaged. So the indications are quite clear. Mitral stenosis, if it's going to be severe, has to be intervened preferably after 28 weeks. All intervention preferably after 28 weeks is clear. And usually such patients tolerate the regurgitation very well. So it's the stenotic lesions. Either it can be a subvalvular or supravalvular, like coarctation. Subvalvular like subvalvular aortic stenosis or mitral stenosis or valvular aortic stenosis. These patients do not do well during pregnancy if they are going to have severe symptoms. Pulmonary stenosis, yes, if they're severe with RV dysfunction, we may have to consider percutaneous balloon valvulotomy. And most of the regurgitation lesions, they tolerate pregnancy well. They may need some amount of inotropic support or vasopressors. However, they usually tolerate pregnancy well. If the patient previously has got a bioprosthetic valve and it is regurgitant, patient has to be, and the patient is quite sick, percutaneous procedure can also be considered like valve-in-valve procedure. Usually, we avoid referring the patient for surgery unless it is a very undoable. Otherwise, the outcome of the fetus is going to be quite dismal if the patient goes into surgery. The maternal mortality is also higher. However, fetal mortality is quite high if the patient enters into surgery. So when to intervene mitral stenosis? If it's going to be severe, critically severe, that is less than 1. In general, it has to be performed after 20 weeks. In this Western country, in our country, it's going to be 28 weeks because we are not that comfortable salvaging a fetus after 20 weeks, between 20 and 28 weeks. However, it should not happen at the cost of mother. If the mother is sick, do it. First priority is mother. So this is the ESC guideline that says that PTMC, percutaneous mitral commissurotomy, should be considered in all pregnant patients with severe symptoms or systolic pressure more than 50, despite medical therapy. And the medical therapy is diuretics, beta blocker, digoxin. That's it. Digoxin is quite safe in pregnancy. Valvular aortic stenosis. We usually, if the patient is having severe aortic stenosis, we try to treat the aortic stenosis before pregnancy itself. If the patient is asymptomatic and diagnosed to have pregnancy also, we try to continue pregnancy. We give a informed decision with the patient. If the patient is symptomatic during pregnancy and the LV has gone down dysfunctional, and we try to do a balloon aortic valvuloplasty. After keeping a surgical backup, the valve tears, the patient should go for surgery. As I told earlier, it's mother first priority, fetus comes second. Yes, that's for sure, but we should try our level best to salvage fetus also. If the patient has got severe aortic stenosis, which is symptomatic in the form of breathing problem or severe PAH or severe LV or moderate LV dysfunction, it needs to be considered. The risk of fetal loss associated with the aortic, the risk of fetal loss should also be discussed with the patient before encountering such procedures. Coarctation of aorta is quite reasonably easy as compared to aortic and mitral interventions. We go from the femoral artery, put a wire and then dilate it. If the coarctation aorta, if the patient affords for a covered stent, we also put a covered stent. It's quite safe to put a covered stent. Usually, you put a covered stent, most of the complications that can happen do not happen to the mother. However, radiation-related complications still can happen to the fetus. What is angiography? When a patient develops, it is a quite tricky situation actually. When a patient develops a MI during pregnancy, most until proven otherwise, it is a spontaneous coronary artery dissection. When a patient has spontaneous coronary artery dissection, we usually rule out few diseases like fibromuscular dysplasia, autoimmune diseases. Other one is patient can be pregnant. If the patient is pregnant, usually it happens during the first month of pregnancy. For some reasons, possibly estrogen-induced some kind of vasculogenesis problem leads to this pathology. In general, doing less is more in such patients unless patient has this clinically sick in the form of heart failure, severe heart failure, cardiac shock, electrically sick in the form of ventricular tachycardia or ventricular fibrillation, or hemodynamically sick in the form of cardiac shock. Unless these three things are not there, that is clinically sick, not there, electrically sick, not there, hemodynamic sick, not there, we do masterly inactivity because it doesn't man. We usually handle such sick patients if the patients are not pregnant. However, the pathology here is quite different. It's spontaneous dissection. It's quite difficult to wire, and we don't know where to land the stent, where to put the stent. And patient has to be on high dose antiplatelets, which can harm the fetus during that time. And most such patients scared actually heals very well. So we used to give only one antiplatelet, no, not even a second antiplatelet, and the beta blocker. If the patient is going for coronary intervention, we give DAPT, aspirin, clopidogrel, explaining the risk of clopidogrel-induced fetal issues, and then beta blocker. Otherwise, we do not intervene such patients. This is the same thing. SCAD, as I told earlier, conservative therapy is preferred and is most commonly seen in first month of pregnancy. So coronary angioplasty primary is recommended as the preferred reproductive strategy during STEMI in pregnancy. This is completely different situation. Patient can develop, for example, can develop a MI, STEMI, ST elevation MI. And in that such situation, we use primary angioplasty is recommended instead of reperfusion therapy, that is thrombolytic therapy, because the reperfusion therapies can cause uterine hematoma and can cause dissection of the placenta from the uterus. So all these things can happen. Hence, angiography followed by coronary angioplasty is the preferred therapy. In general, we do place a stent if it is not a SCAD. If it is a SCAD, we avoid putting stent. That's it. Pulmonary embolism, there is no big difference in the management of pulmonary embolism in patients with or without pregnancy. As I told earlier, we have a huge data that says that the mortality of pulmonary embolism, if the patient is going to have a massive pulmonary embolism, that is cardiac shock, is 30%. It's much higher than acute MI actually. So we don't discriminate patients whether they are pregnant or non-pregnant. If the patient is going to have intermediate, that is only RV dysfunction, we treat the patient with IV heparin, explaining the risk that this can lead to placental issues inside the uterus. And if the patient is have a low risk, we give again heparin. Once the patient gets stabilized with heparin, we continue the patients on injection low molecular heparin, and preferably throughout the pregnancy low molecular heparin rather than swapping to warfarin. We avoid direct oral anticoagulants, and they are not recommended during pregnancy. If the patient has got a massive pulmonary embolism, there is no other way. We have to do thrombolysis, either systemic or catheter-guided. Having said that, catheter-guided thrombolysis doesn't have much strong data to be efficacious as compared to systemic thrombolysis, even in a regular patient, that is non-pregnant patient. So always keep mother first. If it is the pulmonary embolism, cardiac shock patient, massive pulmonary embolism, we have to thrombolyze the patient, explain the risk, and be ready to salvage or kind of sacrifice the fetus. Mother first always. This is a pretty difficult disease to treat even in a non-pregnant patient. Okay, how about heart failure? Unfortunately, all the three drugs, we call heart failure as 4 pillars of heart failure that include drugs that inhibit renin-angiotensin aldosterone, renin-angiotensin system, drug that inhibits sympathetic system, that is beta blockers, drug that inhibit aldosterone, that is aldosterone antagonism, drugs that inhibit SGLT2 inhibitors. Among all these drugs, except for beta blockers, all three drugs are contraindicated in pregnancy. So we are going to treat this patient. Suboptimally during pregnancy. I do have a patient who had a MI at the age of 35. Actually, he was on he had moderate LV dysfunction. For 4 years, she didn't have pregnancy, and then at the age of 39, she came to us. We discussed with the family and the obstetrical team. Patient conceived. We stopped all the drugs, 6 months gap, conceived, and then went for pregnancy. And during that time, we de-escalated drug. Having said that, de-escalation of all these important heart failure drugs will make the patient sick. All these things has to be discussed with the patient. After discussing the pros and cons, she went for pregnancy. He has delivered the baby. Both of them are doing good. So our fear of making a patient having a worsening clinical symptoms should not make the patient to kind of avoid their pregnancy. So a kind of a dare attempt should be considered, provided the patient and the family is willing to take the risk. So one disease that needs to be emphasized is peripartum cardiomyopathy. If there is going to be peripartum cardiomyopathy, cardiogenic shock, understand that the patient is going to be in shock. How much ever inotropic support or vasopressor you are going to give is going to harm the patient. It's because of catecholamine the disease has happened. Based on the severity of the disease, we used to treat the patient. For example, we encountered a patient where a patient had entered into peripartum cardiomyopathy after delivery, with actually 2 days after delivery, severe cardiogenic shock. Patient was on inotropic support, but then we went and stopped all those drugs. We have a low threshold to use a drug called as levosimendan, which does not act on, it's a non-catecholamic inotropic agent and vasodilator. So we have a low threshold to use a levosimendan, and there's something called as intra-aortic balloon pump. They do wonder in such patients actually. Once you put levosimendan, IABP, and you can completely come out of such inotropic vasopressors like noradrenaline, vasopressin, and gradually the patient improved, went home alive. These are all the things that could be considered in such PPCMP patient. With this last clinical example, I would like to finish my talk. Thanks to Dr. Justin Paul from MMC, who's an authority of Empire Registry. I would say he's master of cardio obstetrics. Here is a 30-year-old female patient, 26 pregnancy, pulmonary edema, diagnosed to have severe mitral stenosis. This is the ECG of the particular patient, showing some amount of extra depressions in V1, V2, and the right axis is right. Patient more likely to have a severe PAH. So this is the echo of this particular patient. You can appreciate the valve is quite narrow, quite thickened, and the valvular area is nearly 1. The gradient, what we call it as a mean, this is severe end diastolic gradient, and the mean gradient is something around 28. So this patient underwent, this is the echo of the particular patient. The valve is not much calcified. So this patient underwent a low-dose ALARA-based 3.75 frame-based fluoroscopy assisted intervention, following which the patient underwent a balloon mitral valvotomy. The LA was quite huge, hence he encountered difficulty in getting the balloon inside the LV. However, ultimately it was done. The patient had a acute pulmonary edema after the procedure. The valve area increased from 1 to 1.45. The gradient dropped down from 28 to 8. Patient had an eccentric moderate MR, and then patient went home after 4 days of diuretic therapy. She is doing well. So preconceptional counseling plays an important role in identifying high-risk patients. The role of interventional cardiologist during pregnancy is only to rescue in dire situation. We actually do less during pregnancy. Less is more in pregnant patient, not for all. If the patient is quite sick, yes, we have to go ahead and be humble to refer the patient to an expert interventional cardiologist who does maximum number of pregnant associated procedures. There's no harm in getting their help also in your institute if it is needed. And prepare the patient before pregnancy. The best modality of treatment should happen before conception. Thank you.
Thank you, Dr. Narendra, for bringing in key points. And it's so very important to, do the preconception counseling. We do get a lot of patients who become pregnant and, cardiologist refers do MTP. It's so easy to say do MTP, but we know what are the problems. So it's very, very important. I'm sure a lot of youngsters, I think it's very important that we evaluate and counsel the patients who are already with known heart disease, that what are and at the same time, as Dr. Nagendra has told, it's not that every woman with cardiac disease should undergo termination. No, even with failure, they can go through the pregnancy, and we should not deny them of becoming pregnant. Thank you once again, and over to you, Dr. Shishrika, to take over.
That was an excellent presentation, Dr. Mupati. And this is the common thing that we face in our cardiac practice, especially peripartum cardiomyopathy women, surviving the first and then coming and asking us whether we should continue the pregnancy. That is a common question that we have been asked, and it depends on what was the residual LV function, and even if the residual function is returned to normal, we have to do a proper counseling and go ahead. But your points on how to reduce the radiation and how to plan the procedure, especially your point on letting go of the ego and referring cases to the person who does the maximum cases in that particular category, it's very well taken. And thank you so much for this excellent talk. Thank you.
Thank you, ma'am.
Now it's my pleasure to welcome Dr. Lakshmikant. In fact, we all work together at Gopal Gowda Hospital, taking care of critical care patients. And he is a consultant both at Gopal Gowda and Arya Hospital of Mysore. He's an excellent teacher in critical care medicine. And he's the director of IMPACT program. There is ICU management programs and clinical training. He's organized the South Zone Critical Care Medicine Conference in Mysore in 2019. There is a faculty at various state and national level conferences. And he's got multiple publications to his credit. Over to you, Dr. Lakshmikant, for your talk. Thank you.
Yeah, thank you, madam. Thank you for a nice introduction. And I would like to thank Society of Maternal and Fetal Medicine Mysore chapter and JSS College of Obstetric Department, JSS College, for inviting me on this occasion for the discussion on fluids in labor patients. We also thank Sushma madam and Hemapriya madam for giving this opportunity. Thank you, madam. Yeah. We'll be discussing on fluid management in labor. So like we all know, pregnancy is a special case, especially coming to critical care department or ICU, because it's a dynamic state of physiology where a mother physiological status varies from first trimester to second trimester, then to third trimester. And there are various complications of the disease process. The mother is at risk of developing into like preeclampsia, eclampsia, hemorrhage, cardiac issues, pulmonary thromboembolism. So these are the various, like this has been discussed earlier, like coming to close to the end of the term, patient is at its, the mother is at its maximum cardiac output status. The SVR is significantly reduced at the term, and the heart rate is slightly on the higher side at the term, and the blood pressure, which was slightly lower, is again at its normal near the term. So any patient who requires fluid or ending up in any sort of the complications or shock, ending up requiring fluids or a vasopressor dose with secondary to any of the complications can be categorized into hypovolemic shock or septic shock, cardiogenic or obstetric shock. We'll just, whenever we diagnose these, the management with respect to the fluid resuscitation part varies from each case to case. So we'll discuss one by one, going by the case scenario. And coming to volume expansion, especially whenever we try to treat a patient with shock, we would know what is the optimal level of fluid we're supposed to give. So to know the patient, whether it is fluid resuscitative, we need to evaluate the patient, examine the patient. Patient has to undergo a couple of procedures so that we don't overload the patient or we don't resuscitate a patient who may not be responsive to fluids anymore. So volume expansion has always been a crucial therapeutic dilemma. No matter how many cases you have been treating, each particular case varies, and the fluid requirement in these cases varies from patient to patient. And we need to target patients who benefit from volume expansion and identify who are not benefiting or where fluid can be dangerous. Even a bolus of 500 ml can be dangerous in a couple of patients. We need to categorize them beforehand while we overload the patient. So fluids are drugs too. We always need to very carefully use the fluids. Anything under resuscitation is also dangerous, and over resuscitation is equally dangerous. We'll discuss in subsequent slides. And earlier, like we used to use central venous pressure or pulmonary artery occlusion pressure as a fluid resuscitation markers. Now they have been proven beyond doubt through various meta-analysis that they are not the ideal markers to resuscitate any patient with respect to fluids. So there are dynamic parameters like pulse pressure variation, aortic inferior vena collapsibility index, or stroke volume variation, cardiac output measurement. All this can be used bedside so that we can optimally resuscitate the fluid with resuscitate the patient with fluids. So our goal not to end up with overloading the patient and drowning the patient. Like we as a critical care specialists are at times accused of overloading the patients, especially it was a very common term by our teacher, Ramiraj Gopalan, that is, we fill and kill, and probably nephro, cardio, they fry and dry. That is what he used to say. So primary aim would be, we don't fill and kill the patients. Let's see how to go about it. So we all know, like whenever there's a blood loss, body tends to react by like tachycardia, BP variation, in normal non-pregnant category of patients. While in pregnancy, for them to show sign of shock or hypovolemia, patient has to lose at least 25% of their blood volume. So until then, the patient may not show any sign of hypovolemia or shock, which are masked. The signs and symptoms may be masked in a patient, in a labor patient. So we need to be doubly cautious while dealing with such cases. Any volume loss should be definitely addressed immediately rather than waiting for signs of clinical hypovolemia, because the clinical signs and symptoms may be delayed here. So how to go about? Like we just discussed, I just said that we need to identify a patient who is fluid responsive. So to know somebody who is fluid responsive, there are various categories, various tests that are available or clinical decision-making tools. So we are basically concentrating on this Frank-Starling curve, where the minimal amount of fluid will elicit maximum cardiac output or a maximum stroke volume. So we are basically trying to identify such a group of cases and rule out a group of patients where any volume is going to be harmful, which does not result in improving stroke volume. So in case we are unable to or not assessing this patient into a fluid responsive and non-responsive, it is just like a flip of a coin, where we can go wrong in 50% of the cases, which is quite significant. So having said, as we use echo and ultrasound probes, it is going to be technically difficult in a term pregnancy, as a couple of views are extremely difficult, and inferior vena cava is compressed by a term gravid uterus. So it is going to be difficult, and hypochondriac view of IVC is also going to be not that easy to measure. So there are some technical difficulties which we'll have to overcome while we are evaluating such patients. Going by the evidence, what tests we can do in the patient of a term patient in labor, rather than the routine cases which we do regularly in ICU, such as pulse pressure variation and passive leg raising tests, cardiac output measurement. What can be involved in a patient in a labor patient or a term gestational patient? So preload assessment in the form of measurement of velocity time integral or bioimpedance techniques have been measured, which are relatively non-invasive and can be measured bedside, but provided we need to have some basic knowledge of measuring velocity time integral and calculating cardiac output based on this. And bioimpedance technique is also again a non-invasive technique, which can help us in a bedside. So what basically we are doing is raising the head end of the patient, the mother, by 45 degrees. Keep the patient in that position, say about for 4 to 5 minutes. Then raise the foot end as shown in the figure. Wait for about 90 seconds where we get the optimal stroke volume measurements. So in this posture, measuring velocity time integral or bioimpedance techniques, improvement in stroke volume will give us the idea that patient can be fluid responsive. What we're basically trying to do here is it's an auto transfusion. Whatever was pulled in the peripheries is being pushed back into the central circulation system. About say 300 to 400 ml of blood is auto transfused in this change of posture, which can be measured as a VTI or a bioimpedance signals. Bioimpedance signals have not been very well validated in pregnancy, but there's this article which compares and says they can be of equal importance while giving us the inputs with respect to assessing the preload status and volume responsive patients. These two are non-invasive, which can be safely used on bedside with some decent training by a critical care specialist or an obstetrician either. And there are a lot of invasive techniques which we use. A couple of them are LIDCO, PICO, flow track, and stroke volume, pulse pressure variation with arterial line. Among these, many are again not very well validated in pregnancy or term gestation. There were a few articles suggestive where LIDCO has been utilized on the term gestation period, which has been shown to give a reasonably accurate results of fluid responsive status. But the issue here is most of these have been studied on a intubated patient where tidal volume has been optimal, say 8 ml per kg body weight. When the tidal volume goes low, the interpretation of given by this way of the invasive assessment can go down. The sensitivity specificity can go down. Again, coming to a spontaneous breathing patient, the sensitivity specificity is just close to say 65% or 70% maximum. While on an intubated patient, it can be as high as 85 to 90%. There are a couple of articles where this lithium dilution techniques have been used to assess fluid responsive state, especially in a intubated patient. So somebody who has got a well-equipped ICU or dealing with very complicated pregnancy or gestational period can utilize or incorporate these technologies in their day-to-day practice to assess. And this lithium that has been used also is a very small quantity, which is not harmful to either mother or the fetus. So these two category of patients, along with like the earlier speakers have said, the clinical examination, the assessing the blood volume visibly or measuring your gauze pieces or the MOPS and quantifying the blood loss also play equally important role, and they have been involved in various studies where the amount of fluid resuscitation has been put forth. So clinical assessment, manual measuring of the blood loss, along with utilizing the help of the technology here as a passive leg raising test with a velocity time integral or bioimpedance technology, or involving LIDCO, invasive technologies can help us to a larger extent in optimizing the fluid administration in the patient. So why we need to worry so much about replacing fluids? For that matter, any patient, either it can be in a patient of labor or in any category of patient in ICU. So fluids have been kind of said to be overloading fluids have had a very detrimental effects on the patient health. Okay, before we go to that, so what sort of fluids we are choosing? Should we use colloids? Should we use crystalloids? A couple of studies or meta-analysis which have been done in a very, you can say these are the landmark studies, SAFE study and the crystal study, which says colloids and crystalloids are equally effective, and colloids, especially the non-albumin ones, have been shown to have a lot of issues with respect to coagulopathy, volume overload. So crystalloids said to be good compared to colloids. So you can use crystalloids alternating to normal saline or ringer lactate. And again, a crystal study, which again said crystalloid versus colloids. Crystalloids did better compared to any of the, or at least equivalent to colloids. You can safely use crystalloids rather than thinking of colloids. So whenever we are using crystalloids in a larger quantity, just make sure your plasma chloride levels are well maintained, because hyperchloremic state can push the patient into hyperchloremic metabolic acidosis, wherein the afferent arteriole goes in for a constriction. Patient can land up in acute kidney injury or renal failure just because of the hyperchloremic status, which was already probably complicated by the fluid loss and other various situation where the patient was in. So just monitor the chloride level whenever we are hydrating the patient. Okay. So coming to blood, just I would like to highlight, this is again a landmark study which says targeting a hemoglobin of 7 gram is equivalent to targeting 10 to 12 gram. So restrictive fluid strategy, restrictive blood administrative strategy, like sir recently just said, it's like doing less in medicine is of more benefit than doing more in day-to-day practice. So targeting hemoglobin of 7 to 9 gram percent is equally effective compared to that of 10 to 12 gram, where we end up using less blood products and less of a complications with respect to blood and blood products. So we know that we should be very cautious while using blood products or fluids for that matter. So whenever we encounter a patient of obstetric hemorrhage and hypovolemia, where we are trying to resuscitate with a lot of fluids around, there's something called triad of death we should be aware. It is nothing but the coagulopathy, the acidosis, the hypothermia that sets in. Patient has been bleeding, obstetric hemorrhage is coming to you, probably she's lost a lot of volume, she must have been hypothermic. So before we resuscitate, try to use warm fluids or warm the patient, try to get to the normal temperature, or warm fluids can mitigate hypothermia. And volume loss, hyperchloremia, multi-organ dysfunction could have set the patient into hyperlactatemia, could have set the patient into acidosis, and coagulopathy as well. Coagulopathy again can be worsened because of if we are overzealous hydration. So optimal hydration again plays important. So whenever we are encountering a patient of hemorrhage, especially obstetric hemorrhage, for that matter, think of hypothermia, coagulopathy, acidosis, because when these three parameters are noted in any patient, the mortality in that case is going to be as high as 48%. So there is 50% death in such patients. Whenever we see, measure them and try to avoid them. If the patient is already set into this, actually this concept came into something called damage control surgery in a setting of trauma, where this was monitored and the mortality was measured and it was said to be extremely high. So the surgeon then, instead of doing a complete repair of the solid organ of the visceral injuries intraoperatively, they started using damage control surgery, that is just stop the bleeding and get out of the OT. So longer the time you are in OT, longer the complications we are landing up into, and more is the mortality. Again, the same probably will hold good to the obstetric cases also, coming with massive bleeding. So now we know more of fluid are probably dangerous to the patient, or optimal fluid is the target that should be. So what is that our green top statements, what does it give by the RCOG? They say, until blood is available, infuse up to 3.5 liters of warm clear fluids, initially 2 liters of isotonic crystalloids, whenever the blood loss is a liter or more. But there are some schools of thought that says this volume could be slightly on the higher side. 3.5 liters in a term patient coming with an obstetric hemorrhage can be on a higher side. So there have been schools of thought, there have been studies which have been put into, but they are into very early phase. There's nothing that is conclusively said that this is more, but there is a trend that is suggestive of this could be more. Okay. So the publication published by the Association between Fluid Management and Dilutional Coagulopathy in Severe PPH, nationwide retrospective cohort study done in Netherlands, did say that, I can just run through the slides here. If you could see the amount of bleed, that is 1 to 1 liter or 1.5 liters on the top, and the fluid resuscitation to say 0 to 2 liters, 2 to 2.5 liters, 2 to 3.5 liters, and 3.5 liters. As more amount of fluid has been administered, the hemoglobin has been dropping, the hematocrit has been dropping. So again, probably restrictive strategy wouldn't have led to drop in hemoglobin here, probably. And again, the similar trend while we use more fluids, the platelet counts have been in a kind of dropping trend. And fibrinogen levels also, the levels have been coming down as we've been giving more of fluids, as close to 3.5 liters compared to less than 2 liters. So again, your coagulation parameters tend to be deteriorating as we give more of fluids compared to less than 2 liters compared to more than 3.5 liters. So what does this say? This definitely did not say that restrictive fluids were better than liberal fluid assessment or a treatment, but what that did say that reduced transfusions, it did require less number of transfusions, and this is kind of one of the quantitative evidence to reinforce the expert opinion based, where we need to probably come down on the fluids what we are using. Okay, and as we are doing less of transfusions, and there is evidence that probably restrictive fluids may be better, and the adverse outcomes also could be less. Again, one more study which was published recently, 2021, a refill study, did emphasize the same inputs. Again, a study from Netherlands, where restrictive strategies did show some inclination towards better outcome, but they did not say that restrictive was better than liberal approach. But we know that setting enough coagulopathy, hypothermia, and volume overload can be disastrous. So maybe we can just think of using relatively less fluids than what we are using. So again, pregnancy, like we discussed, the cardiac output at its peak, the plasma volume is at its peak, and this clinical scenario will unravel any hidden cardiac abnormalities the patient is coming with. If it's a booked case, maybe like Madam said, we are subject to them for an echocardiogram, where we are trying to screen for a pre-existing cardiac issues and manage them better. But somebody which is an unbooked case might come up with a pregnancy that is complicated by various clinical conditions because of high plasma volume, high cardiac output status. So what diseases can also predispose them to cardiac abnormality are like preeclampsia. Various studies or retrospective analysis has said that there are 71% increased risk of cardiovascular mortality or diseases, 2.5-fold increase in risk of coronary artery disease, 4-fold increase in risk of heart failure, just like the previous speaker has highlighted. And women with pre-existing coronary artery disease is considered to be at a high risk probability of developing IHD, more or less about 10%. And in patients with cardiomyopathies, the patients requiring heart transplantation, LVAD, especially where ejection fraction is about less than 30%, is extremely high. Anything more than 40%, they say in case they are well managed during the labor, they improve over a period of time. But some subgroup of cases where ejection fraction is less than 30% will end up in cardiac transplantation or requiring assistance for the cardiac output. So what did the circulation did say? That is AHA scientific statement, that is cardiovascular consideration in caring for pregnant patients. Up to 23% of women experience heart failure or arrhythmias related complications in the third trimester or postpartum. And the left-sided stenotic valve lesions are associated with the higher risk. And valvular regurgitations are relatively well tolerated during pregnancy. And DVT again is about 4 to 5 times more common. And because the D-dimers are very already probably elevated, it may not be optimal to measure or get a clinical outcome based on just D-dimer. And more so, the venous thrombosis are more proximal here. We might end up missing the distal venous while we are looking for a Doppler. Only in the distal venous veins, the proximal veins can be missed. DVT in the proximal veins can be missed. And already the dilated chambers would also probably make it a little more complicated to very classically explain the pulmonary embolism scenario. So again, coming back to fluid resuscitation, probably these are the subgroup of cases where we need to be more cautious, like dilated cardiomyopathy, pericardium cardiomyopathy, mitral stenosis, and aortic stenosis, where the moderate AS could become a kind of severe aortic stenosis because of the various hemodynamic status that the mother is going in. So like here, these are the cases we'll be using restrictive fluids and more of a diuretics to stabilize the patients as probably they are into pulmonary edema or early pulmonary edema. The other subgroup of cases which we come across probably hypertrophic obstructive cardiomyopathy or left-sided regurgitant lesions, which are dependent on preload. We need to resuscitate them optimally with fluids. We need not restrict them, and very cautious use of diuretics. These two are just broadly categorized. There are a lot of other things that needs to be monitored and measured while we optimally hydrate them or resuscitate them. So just it's a broad categories where with respect to fluids, what is the term, what is the term, what we are probably going into. So mortality has been attributed in term or young pregnant women of late. It is because there is increasing number of women at advanced maternal age undertaking pregnancy. There are comorbid pre-existing conditions, diabetes, hypertension, or the pre-existing cardiac abnormalities, which have been well managed, and they end up getting pregnant and coming to the obstetrician or the cardiologist with pregnancy, where they should be managed by a team of cardio obstetrics. Okay, and other issue has been pregnancy has been excluded from most of the RCTs because of the risks to mother or the fetus. So a lot of studies did exclude pregnancy or especially the term gestation, so that the recommendations with respect to many of these things are coming up, or most needs to be undertaken, involving a safer techniques involving mother in the term gestation or in the labor for that matter. So carry home message is like optimally fluid resuscitation amounts to all the group of cases. It could be labor patient or patient ending up in ICU because of various reasons. Clinical parameters definitely are of great help in deciding, and there are bedside tools which are non-invasive, like velocity time integral and calculating the cardiac output based on that, because other techniques can be little suboptimal here. And whenever, if we are resourceful setting, if we can have a cardiac output, invasive cardiac output measurement devices, that probably are going to help us optimally fluid load the patient rather than overloading the patient, which is going to be extremely disastrous for the patient. Thank you.
That was an excellent presentation, Dr. Lakshmi. You've covered almost all aspects of fluid overload and how the cardiologists kind of go dry on everything, and you guys kind of emphasize on physiological measurements and then guide your fluid therapy. And the past decade, I think we have kind of used the ultrasound to manage our fluid therapy in intensive care unit, which is also applicable for our pregnant and postpartum women. And thanks for the excellent lecture, Lakshmi.
Thank you.
Thank you, Dr. Lakshmikant. Of course, it was a very excellent, elaborative lecture. And of course, the preliminarily obstetric cases managed by an HDU. So all the obstetricians should have a very good knowledge about the fluid management. And of course, this is team efforts. And as we know that PPH is the primary complications nowadays, hypertension. And in these scenarios, and of course, the cardiac diseases adding to the complications, we should be very well versed to have a high index of suspicions and to manage the fluid accordingly. And you brought in the concept of the teamed effort and other modalities of measurements of fluid, everything. I think that was a very good discussion happened. And we should be nowadays very much keen that this hypertension especially will push the patients towards the future IHD and many other long-term medical diseases. So this early intervention will definitely help us to manage the women in a long term. Thank you.
Thank you.
So we can move on to the next lecture, and it's again a great pleasure to introduce my friend and colleague, Dr. Madhura Pathak. And she's a consultant obstetrician and gynecologist at Motherhood Hospital, alumni of Kasturba Medical College and Bangalore Medical College, and MRC OG from London and FRC OG. And she has a fellowship in urogynecology and vaginal surgery, and also a fellowship in laparoscopic surgery. She has an excellent academic record, and her previous attachments were with NHS and with us in Colombia and Manipal, and our journey in managing the women continues even in Motherhood Hospital. Over to you, Dr. Madhura.
Thank you, Dr. Shashirekha, for kind introduction, and I thank SFMI Mysuru chapter for asking me to present this topic, and Mr. Amit of Encure Pharma for sharing their some of their slides. Moving on to the topic of anemia in pregnancy, I think all the speakers today have given a kind of anchoring for my topic. We see pregnant women day in and day out with, half of them are anemic. And when it comes to the trio of anemia, pregnancy, and cardiac diseases, I think it is the most dreaded one that we could all imagine if we encounter one. And these scenarios have to be managed in a multidisciplinary manner. Dr. Satish did give us an overview of mortality rates of in cardiac disease. It's around 2%. And in people who have anemia, the mortality rates of congestive cardiac failure can double from around 25% to 50%. So it is quite important that we start investigating and treating pregnant women with the cardiac disease from early on. As such, in our society, we know that nutrition is the most important factor. We do know that the daily necessity for iron intake is around 0.5 milligram in very early pregnancy, and it can go up to 7 milligram requirement in the late pregnancy. And regular diet that we follow can only probably give half of this requirement. So when it comes to the causation of anemia, most common is the nutritional deficiency. But as the disease, the cardiac disease itself is a chronic disease, then comes the picture of all the inflammatory markers having impact on erythropoiesis and increase in the hepcidin levels, which is a peptide hormone, which reduces the uptake of iron in the gut and reduces the erythropoietin production in the kidneys and bone marrow. So how we manage the anemia in these patients really depends on the pathophysiology of the disease. And of course, there are other reasons where, because of the medications used in patients like anticoagulants or aspirin itself, may have blood loss related anemia. And gut malabsorption again comes to the anemia of chronic disease. So the reasons for anemia is the one how this will give the answer how to treat anemia in these patients. So most of the time it is about prevention, and we do start most of our patients from the beginning of pregnancy itself, at least once they have completed their third month. Once their appetite gets improved, we do start them on iron and vitamin supplements. And some of them may not tolerate, and then in these people, we do have to supplement the iron or other vitamins through the parenteral route. Adjusting the anticoagulants and heart failure medications is another consideration in these patients. And I'll be touching upon a little role of blood transfusion. Dr. Lakshmikant did mention about blood transfusion, but we'll be touching a little upon that, and use of erythropoietin, because this has a role in anemias of chronic disease. We do know how to diagnose anemia, but when we consider treating anemia, especially if they have not responded for the oral iron therapy, or in patients with conditions like thalassemia, we do have to rely on other markers, the blood test, the ferritin levels, and transferrin saturation. Serum iron itself is not the best marker because it shows some variations from time to time, and diurnal variations also. So to define anemia, the ferritin storage iron is used to confirm, especially before planning on to give parenteral iron or IV iron therapy. Now, I'll just go through the blood transfusion. As the previous speakers have rightly said, less is more. And the indications for blood transfusion is only if there is a severe anemia and anemia because of acute blood loss, which can be conditions like placenta previa or postpartum hemorrhage. In such situations with cardiac condition, it's always better to manage them in ICU with the input from intensivist and cardiologists. And also using diuretics to prevent volume overload is a good thing to consider. And they have to be monitored well post-transfusion as well. And it is okay to maintain them at a moderate level rather than opt for a higher level of hemoglobin, which is definitely has not shown to increase the outcome, or in fact, they may increase the mortality rates in these patients. Now, it's quite interesting to note that erythropoietin, which has been used for ages in chronic kidney disease, has also been used in people with anemia in pregnancy, and it is found to be quite safe. The erythropoietin usage, although it is quite expensive, it has an important role in patients who do not respond to the oral iron or have some adverse reactions for the previous iron injections. And the amount of hemoglobin that arises with these kind of interventions is quite comparable to IV iron itself. The effect can be noted from 2 weeks itself, and by about 6 weeks, they do reach quite a good level of hemoglobin once given. But some of these, of course, the patients may not be able to tolerate because one injection of erythropoietin is, I think it is costing around 10,000 rupees. And they may need recurrent injections to maintain especially because of chronic conditions, in conditions like chronic failures. Some of these injections may also result in hypersensitivity reactions and thrombosis, especially in hypercoagulability status. The thrombosis is also a risk. Probably the most important drawback is the cost. But yes, it is one of the thing to use instead of blood transfusion in these patients. And this is a slide which shows the Cochrane review. And in this, we do see that the one in the red, that's the IV iron, is the one which has improved the cardiovascular events, exercise tolerance, and quality of life in these patients compared to the blood transfusions or erythropoietin supplements. In fact, blood transfusion did not show any improvement in mortality or morbidity in these patients. Now, we have just seen that the IV iron probably is more suitable for our patients. There are different types of IV irons: dextran, sucrose, and carboxymaltose. Of all these, the iron carboxymaltose has shown to have less immunogenic potential with less reactions, and it has the advantage of possibility to give in a larger dose in a short span of time. And the amount of iron can be given in a small dose in 100 ml of saline, which is good for our cardiac patients where we want to avoid volume overload. And in general, there are different ways of calculating the iron necessity of iron dosage based on the weight and the hemoglobin level of the patients. But most of our patients can be given 1,000 milligram of iron, even without much calculations, just based on the hemoglobin. This is the formula that could be used. And this iron, if it is 500 milligram iron, can be given in 100 ml of saline over 6 minutes. And if it is 1,000 milligram, it can be given over 15 minutes in 250 ml of saline. And there have been quite a lot of studies which did show that IV iron with FCM did increase the hemoglobin significantly over 3 to 6 weeks time. And there was almost increase of 4 to 5 grams in people with severe anemia as well. So now there are a lot of studies which have shown that FCM did not only increase the iron, the hemoglobin levels in a short span of time, it did also improve the morbidity, and abnormal neonatal outcomes were less in people who were treated with the iron in terms of low birth weight scores, mortality rates, neonatal admissions, and Apgar scores as well. Definitely, there is no way of managing these people without collaboration of with cardiologists, ICU, intensivists, hematologists. Yeah, with this slide, I want to finish my presentation. Thank you.
That was a nice talk, Dr. Mathura. And I know, I mean, in cardiac disease itself, anemia is present in about 10 to 15% of the population. And cardiac disease with anemia, as you put, is it's a dangerous combination when pregnancy is added to it. We are appreciating this multidisciplinary team approach. That's why this whole concept of this cardio obstetrics has come into place. And thank you very much for that lecture, Dr. Mathura.
Thank you.
Congratulations, Madhura. She's our EC member of our SMFMI society. Indeed, it was a great presentation. Of course, in pregnancy, we should target anemia. Without targeting anemia, every other disease management is incomplete. So that is our national program, which is aiming at Anemia Mukt Bharat. It was indeed a great talk and a part of our discussions.
Thank you, Dr. Sushma.
We have our very eminent guest, the chief guest, Dr. Sampath Kumari ma'am, has joined right across from our air travel. We welcome you heartily, ma'am. It's a great pleasure that you are with us today. She's the immediate past vice president of FOXI Federation India, and the professor and HOD of Shri Muthukumaran Medical College. We heartily welcome ma'am for today's program. Over to you, ma'am.
Thank you, Dr. Sushma. I was in the flight, so I couldn't join in the early morning. And 1 o'clock, and now I'm in Allahabad for a CME. So first of all, congrats.
Ma'am, you are muted.
Dr. Revati. This cardio obstetrics in Tamil Nadu, Dr. Justin Paul is doing the series of webinar as you are doing, but it is really needed. Now we have taken the important topics like minimally invasive fluid management, anemia. I was hearing about that FCM. We are also using this FCM nowadays in antenatal. So some studies which tells that it cannot be used in pregnancy, but it is a very good drug that can be used. And as for all other things in the cardiac patient, it can be used with a careful monitoring. So this cardio obstetrics, as I was seeing, the incidence is only 1 to 4%, but the mortality is about 26% in the pregnancy mortality, the cardiac complicating pregnancies, that too with including the peripartum cardiomyopathy. So Sushma, it is nice that you are doing this cardio obstetrics series. I want you to send the link on every meeting and I will join. I wish all the best and success for this webinar. Sorry for not joining in the meeting, and the people will be waiting for the important panel. The panel on postpartum and labor in the heart disease complicating pregnancy. Thank you, Dr. Sushma. Nowadays, we have the cases with LDA disease, that is the cardiac stent, and then they are becoming pregnant. I conducted one delivery, I think. It is more or less like our valvular disease. Thank you, Dr. Sushma. I wish all the success for this webinar. Thank you.
Thank you so much, ma'am, for your encouraging words. And of course, for today's webinar, we have all the delegates logged in all across from the South India. We have almost crossed nearing 400. And it's going to be a very successful discussions, which we are sharing the knowledge through our forum. And we thank every member who are part of this webinar. And now over to Hema to look into the next scientific session.
Thank you, Sampath Kumari ma'am, for joining in. Now let us move on to the panel discussion. Before that, I would like to thank our chairpersons, Dr. Lata Chaturvedala and Dr. Shashireka, for doing an excellent job, as well as all our speakers, Dr. Satish, Dr. Bhupati, Dr. Lakshmikant, as well as Dr. Madhura. Now let us go ahead with the panel discussion. I would like to introduce our moderator, Dr. Shashireka Rengraj. Dr. Shashireka is a professor at JIPMER in the Department of OBG. Madam is an FICOG and has done a short-term fellowship in obstetric medicine. She has more than 15 years of teaching experience and has a keen interest in high-risk pregnancy, with many publications both in national and international journals to her credit. Welcome, Dr. Shashireka. I shall also introduce the experts. We have with us Dr. Sunila Kolluri. Madam is a professor at Osmania Medical College, Hyderabad, in the Department of OBG. She is an examiner for both UGs and PGs, and as well as DNB, and is a trainer of trainers for the Telangana state for various government programs, and has presented various papers in both national and international conferences. Welcome, Madam. Joining her will be Dr. Gitanjali Kattagiri. Madam is a professor of OBG at SNMC Medical College, Bagalkot, and she is also the chairperson of the Clinical Research Committee, Kasoga, which at present is doing a multicentric trial on near-miss cases. She is also faculty at various state and international conferences and has completed various interventional projects in obstetric care. Welcome, Dr. Gitanjali. I would also take the liberty of introducing our panelists. The panelists are Dr. Kavita Tyagi. Ma'am is a consultant interventional cardiologist at Sir Gangaram Hospital, New Delhi. She is a senior faculty for the attached with the National Board of Examinations and has received various awards and has presented various papers as a faculty in both national and international conferences. We have with us Dr. Usha Rani. Madam is a professor of OBG at Sri Ramchandra University, Chennai. She has more than 30 years of teaching experience and has a special interest in assisted reproduction, operative endoscopy, as well as high-risk obstetrics. We all know Dr. Anjali Siddesh. Madam is very familiar to all of us. She was from a former professor and unit head at JSS Medical College. Right now, Madam is the director of Sigma Hospital, Mysuru. Ma'am is a laparoscopic surgeon, infertility specialist, as well as manages a lot of high-risk obstetric cases. We have Dr. Anil Kumar. He is a professor in the Department of Anesthesiology at JSS Medical College, Mysore, and is a member of the obstetric anesthesia chapter. Welcome, Dr. Anil, sir. He is an instructor for BLS, ACLS, and has been an invited faculty at various national and international deliberations. Lastly, we have with us Dr. Srinivas Joyce. Sir is the professor and HOD in the Department of OBG at Bangalore Medical College. He has special interest in high-risk pregnancy and vaginal surgeries. He is an editor for the book OBG textbook on ward rounds and has written various chapters both in UG and PG textbooks. So once again, a warm welcome to all the panelists, the experts, and now I hand over the session to Dr. Shashireka. Thank you.
Respected chief guests, guest of honor, chairpersons, and office bearers of Mysore chapter of Society of Maternal Fetal Medicine, and my dear teachers, colleagues, and dear friends, and warm good afternoon. Thank you, Dr. Sushma, for bringing me through this panel to Mysore, from where I did my PG. And we are having an important topic on heart disease, the series of talk on heart disease in pregnancy. This is one of the important area because. And as we said in the beginning itself, you brought a very good panel of multidisciplinary team for this wonderful panel discussion. So we'll start this panel. We all know heart disease per se is contributing to one of the major causes of morbidity and mortality. But look at the cardiovascular changes which happens during pregnancy, especially to labor. The heightened risk of adverse maternal outcome happens in this period. The changes are much more enormous and quite fluctuant. Not only that, the changes which happen over the period of time from first trimester onwards is going to come down in a short span of time peripartum. So the woman is at increased risk of complications around labor and delivery. Not only that, the risk is going to continue beyond 6 weeks, sometimes 6 months, a year later also. Everybody has stressed upon the important area, that is the multidisciplinary team. And there are various concepts involved in the management of women in labor and delivery. We are going to touch each one of that. And one of the important questions for postgraduates also, how do we manage women in labor? And we need to touch upon each of those components and it will be useful for them. And we have a wonderful panel of experts definitely who will add to this value to this panel discussion. So let's not waste time and start the first case. Mrs. G, she's 28 years preemie, married for a year. It was spontaneous conception. So the known case of RHD, MSMR, since the age of 12 years. She's booked at a tertiary care center. She's on medications, very compliant to her visits as well as medications. She's admitted for delivery. Right now, she's 39 weeks. Her last cardio visit was at 36 weeks, and her baseline investigations are within normal limit. The obstetric assessment shows that it's a singleton fetus and AGA baby, a normal Liker, placenta is anterior high, no contraindications for vaginal delivery from obstetric perspective. Pelvis is adequate. And so far, no hospitalizations, no cardiac decompensation. The latest cardiac assessment shows she's in modified WHO class 3 and the functional status of class 2. ECG is normal. Echo shows a valve area of 1.1 with right ventricular systolic pressure of 38 millimeters of mercury, a normal LV function. Dr. Srinivas, sir, can you enlighten us? How do you plan her intrapartum journey? Give an overview on that.
Yeah. Good afternoon, and thanks for this opportunity for the organizers. Without wasting much time, I just want to proceed with the questions that are posed to me by the moderator. As everyone is stressing, first thing is about the multidisciplinary approach. Of course, we need to coordinate with the cardiologist, anesthetist, and of course, obstetrician myself. Plus, it's also important to discuss the same thing with the pediatrician. And second thing is she's 39 weeks, recently evaluated at around 36 weeks. So concern both for the obstetrician and the patient is, when am I going to deliver and how am I going to deliver? These two questions have to be answered first. And as per most of the recommendations, in this kind of case, you can definitely wait for spontaneous onset of labor up to 40 weeks, and it's not wise to prolong the pregnancy beyond 40. And I think the moderator has different questions for induction of labor, augmentation, and indications for elective LSCS. So I don't want to proceed on those things, but a definite delivery plan has to be framed by this time, when I'm going to deliver and how I'm going to deliver. And most of the information that has been given says clearly that she is a suitable candidate for vaginal delivery, which is the best for any cardiac patient, excepting a few conditions. And about the pre-anesthetic evaluation, and this may differ from institute to institute, because the concept of epidural anesthesia is not there in most of the government hospitals, including my hospital. So we usually rely upon other methods of pain relief for this patient, which is very important. But still, she can land up with the operation theater at any moment. So a pre-anesthetic evaluation also is important. And more than everything, every visit, every time she comes to us, I think we have to reassess the risk. As Dr. Madhura was telling about anemia and cardiac disease, a deadly combination. Here, I also would like to put anemia, infections, and preeclampsia. These are the three important enemies for a cardiac disease. So I need to risk stratify her in every visit. Even now, I would like to look at all these possibilities and try to find out whether she is moving from the previously assessed risk to higher risk. I think these are the things that I would like to plan with this patient.
Yes, the risk assessment has to be ongoing, and we should involve multidisciplinary team in the decision and also the patient in the mode of delivery. So, Dr. Kavita, from a cardiologist perspective, do you think the mode of delivery should be different, or do you want to give any special instructions as far as this patient is concerned? Dr. Kavita is online.
The other cardiologist can take up the question. There must be some problem with the network.
I think Dr. Kavita is not there.
Okay.
We can just continue. I will just till then I will find out what is the problem.
Okay. Generally, when you plan the mode of delivery, we need to consider vaginal delivery is preferred, but we need to consider certain cardiologic hemodynamics before we plan the delivery. Certain selective cardiac conditions, of course, elective cesarean section is required. But as Srinivas said, vaginal delivery is the preferred mode of delivery. It's better to get a cardio review after admission if facilities are available. So, Anil sir, do you prefer to have a pre-anesthetic checkup well before labor or when she is in labor? How do you decide for labor analgesia? So do you suggest epidural for everyone or different modalities of analgesia? As Srinivas said, it may not be available in every facility. And as far as cardiac disease is concerned, in every case, you want to suggest epidural analgesia as the preferred mode of analgesia, or what's the view, sir?
Thank you, Dr. Sasarika. And I also thank Society of Maternal and Fetal Medicine, Mysuru chapter, Dr. Sushma and Dr. Hema, and also Jesus Medical College Department of Obstetrics for having me here with this elite panelist. Yes, I do prefer to have a pre-anesthetic evaluation well before labor. This consultation in most cases should take place near the second trimester or at least the early third trimester. Timing may be individualized depending on the factors including the severity of the condition and the antepartum access to the care. Every patient may not be access to the healthcare facilities. Nevertheless, the early evaluation of the high-risk pregnant woman, probably along with the first visit of obstetrician, what I prefer, what I do with my obstetrician is, with the first visit of any high-risk pregnancy, they should visit the anesthesiologist. That allows us facilitating a comprehensive patient assessment, optimization of their conditions, or to provide education. This is an opportunity for us to educate patients regarding the labor analgesia, the anesthetic management options, the different options available for labor and delivery, or to continue or to stop certain medications. Even ACOG recommends the early anesthesia services involvement as a part of this multidisciplinary approach. That was the answer from the first question. And how do you decide for labor analgesia? The decision on labor analgesia, as Dr. Srinivas Joyce said, it depends on the patient preferences, the stage of labor the patient is in, and the discomfort the patient is suffering, the obstetrician concerns, the experience and the expertise of the anesthesiologist in the center, and the local protocols and the availability of the equipments. The request from a patient, the parturient who is in true labor is enough to decide on labor analgesia. And particularly in the context of cardiac disease, it is initiated as early as possible if it is not contraindicated in that particular individual. I will just go through a rapid scanning of this patient, including a patient consent, the platelet count, what is his coagulation status, whether there is an infection. What I'm trying to say is, I'm ruling out any absolute contraindication in that patient, then we are moving ahead. Then is epidural for everyone? Yes. The epidural must be initiated for all the parturient irrespective of their comorbid condition unless absolutely contraindicated. It is a most versatile and a gold standard technique of pain control in obstetrics that is currently available in practice. Even World Health Organization also recommends that every parturient must be offered the benefit of epidural labor when feasible. The benefits include it is a superior pain relief, both in the first and the second stage of labor, facilitates cooperation of the parturian during delivery, best hemodynamic stability, allows extension in case as an obstetrician or the fetal reasons, whatever the reason, if patient requires operative delivery, it can be extended, avoids the intravenous opioid-induced maternal and the neonatal respiratory depression. Thank you. So alternative labor analgesia, I asked a question on alternative labor analgesia. The alternative techniques may include the non-pharmacological like the psychoprophylaxis, which also helps to a certain extent. The other methods which I am not practicing is acupuncture, acupressure, and hydrotherapy and massage therapies. But we have practicing the TENS, the transcutaneous electrical nerve stimulation works well. The other a small piece of information which is working well with our patient is the sterile water injection technique. A small 0.1 ml of saline at 4 different points in the back that really do well. If nobody is practicing, you can try this on your patients. The other pharmacological modalities include opioid analgesics, non-opioid analgesics, the inhalational. We have got experience using Entonox. That also serves a purpose, and the neuroaxial techniques, which may be spinal, epidural, the combination of spinal, epidural, and the nerve blocks like the paracervical, pudendal, and the perineal infiltration. These are some of the other modes of the labor analgesia techniques. Thank you.
Epidural may not be optional for everyone, but at least for those with severe heart disease, modified WHO class 3, class 4 should prefer to have this because it's going to definitely cut down all the sympathetic reflexes and the burden on the heart. So to minimize the morbidity, at least in those situations, we should have that. When we do echo for everyone, at least we should be able to provide epidural for those with severe heart disease. So that was a plan we had. We had a pre-anesthetic checkup. We thought we are waiting for her to go into labor. The resident in the antenatal ward performed membrane sweeping in the previous evening, and she spontaneously went into labor the next day. Currently, the cervix is 50% effaced, 2 centimeters dilated. We don't know. We're not sure since when she was having leaking, but the liquor is clear with estimate fetal weight of 2.8 kg. So we are not able to, the plan was to have epidural, but we are not able to shift her to OT as the OT is occupied with emergency section. So what is the analgesia we choose right now and how much dose should be given? Usha ma'am? Usha ma'am is online.
Sorry, I didn't unmute. So the sweeping was done by the resident, and this lady has ruptured membrane sometime, looks like. Antibiotic prophylaxis is the first thing that would strike my mind. Yes, infective endocarditis prophylaxis would be started. And she's pretty in very early labor. So pain relief can be offered. We use a lot of Entonox here. So that could be offered. And once the anesthetist is free, we can start her on an epidural analgesia.
So how do we monitor her during labor, ma'am?
Yep. We'll have our patients here on a continuous monitoring the mother, wherein we do monitor her multi-parameter monitor with the oxygen saturation and the heart rate is also monitored. We of course monitor the fetus. And input and output, as we have already mentioned, that we would like to encourage the lady to take a lot of oral fluids rather than give her intravenous fluids. That would cut short on monitoring her IV fluids. Yes, and she should progress well, considering it is an average size baby. And
we should adapt her to have a position whichever she is comfortable, but we should avoid supine position.
Exactly.
If Entonox is not available and epidural is not available, morphine is a very good alternative, especially for women with heart disease. And is sweeping of membrane advisable for women with heart disease, ma'am? What's your opinion?
If you've already taken a decision to deliver her vaginally, she is accepted to take all the risks of induction.
Yeah, we should follow strict asepsis. That's very important. There's no point in doing sweeping every week, probably once when the bishop is favorable. So fortunately, we could give epidural after 2 hours when the slot is available and she's progressing well. And right now she's in second stage.
Madam, 1 second. Can I just add one thing here about infective endocarditis prophylaxis? you have asked a question whether it is recommended. If we go by recommendations, there is no recommendation for laboring women for infective endocarditis prophylaxis. It's a practice in most of the hospitals in India. I just want to stress this point.
Yeah, recommended in our setup. So most of us, we prefer to give infective, and especially with valvular heart disease beyond WHO class 2. So that's our practice. What are the concerns during second stage, ma'am? Do we need to really cut short the second stage? Anjali?
Yeah. At the outset, I like to thank the organizers for having me here. And regarding this patient particularly, we all know that second stage is always dramatic in any hospital. And as an obstetrician, we know how it is difficult in second stage. Coming to this particular patient, she is adjusted with her hemodynamics throughout her first and second trimester till delivery now, and she is in second stage. So these adaptation she has done because the adaptation of hemodynamic changes are quite slow and steady over the period of first and second trimester, and she is very well compensated for that. But during labor, there will be sudden acute changes in hemodynamics. So these can lead to some problems with the patient. Especially this happens that sudden changes in the hemodynamics happens during labor because of pain itself. There will be increasing heart rate. During second stage, catecholamines are released and heart rate will be increased. Then there will be bearing down sensation, which will again bearing down, and sudden contraction of the uterus, which pushes the blood volume into the circulation, which increases the venous return. And again, there will be, if she is in a flat surface, there will be compression of the vena cava. All these things together changes her adaptation to the hemodynamic circulation. And this needs to be concerned in second stage of labor, for which we need to monitor her as a team, which comprises of anesthetist, a trained obstetrician, and more important is surrounding staff.
So we all talk about
the birth position is always either in a left lateral or in upright position. You should never allow patient to lie down flat because it causes the compression of vena cava, which returns, it will cause the hemodynamic changes quite a lot. Coming to the third stage management, it is more dangerous because sudden separation of the placenta and contraction of the uterus again makes the venous return more to the heart. And especially if you are pushing the, if you are doing the manipulation for removal of the placenta, it will be very dangerous for the patient. And it is always advisable to give the oxytocin if patient is having little bit decompensation, then you have to give a slow dose. Otherwise, regular oxytocin is enough for this prophylaxis for the third stage of labor.
Yeah. So in a complicated cardiac disease, definitely alkaloids like methadone is contraindicated. But in a mild heart disease, probably if we are facing with PPH, it's not that it should not be given. We have to be careful about the effect on myocardial ischemia. But otherwise, as Madam said, oxytocin is the first line of oxytocic, and slow infusion, especially if the hemodynamics is disturbed. So she's fine now, delivered and feeding well. There are no lactation issues. As per her request, PP-IUCD was inserted after delivery. Srinivas sir, what are the concerns during postpartum? Like how do we monitor her? Do we monitor her in ICU, HDU, and how do we step down?
It's always better to monitor this particular patient in the HDU. Of course, depending on the complications associated with the cardiac disease. What I mean is, apart from the case scenario that you have posed, if you have a more severe cardiac disease, we may have to continue monitoring them in the ICU. Otherwise, HDU is fine. 24 to 48 hours is ideally a good time to monitor them in the HDU and then step them down. And I think Ian Donald has given a wonderful rule of 5 where he says the first 5 minutes, 5 hours, 5 days, 5 weeks, and 5 months are the critical period. At least here, we can go up to 5 hours and 5 days of monitoring this patient continuously. My concerns are about arrhythmias, acute pulmonary edema, then thromboembolism, infective endocarditis. These are the concerns that I usually have, and they should be monitored for their pulse rate, blood pressure, temperature, urine output, and hydration very carefully to be monitored. Very well said by the intensivist in stenotic lesions how to manage, and in regurgitant lesions how to manage, and early mobilization in cases which we are facing right now, and utilization of non-pharmacological methods of thromboprophylaxis also as far as possible. These are the monitoring protocols that I would like to follow. And yeah, the next question is about PPIUCD. PPIUCD in a cardiac patient with no evidence of infection or ruptured membranes more than 18 hours, which are the general contraindications for PPIUCD, you can definitely safely use them. And in case you have the severe kind of lesions in the cardia, there is some literature which says prophylactic antibiotics can be given, but it is not a must again. So PPIUCD is not a concern. It can be safely used in them.
Do you prefer to consult cardiologist before discharge, sir? And what will you advise on her future pregnancy too?
Yes, madam. Cardiology consultation, as per the ECS recommendation, it is about 3 weeks. If she has been followed up regularly, as in the current case where she has had a very compliant cardiac reviews also, 3 weeks after delivery and about 12 weeks after delivery, a concept of fourth trimester of pregnancy has come up here now. Up to 12 weeks after delivery, you call it as a fourth trimester, coined by an American. And I think we can ask her to have a review at 3 weeks and 6 weeks, 12 weeks, unless she gets into any other complication in the puerperal period. And about future pregnancy, my personal advice, actually, there is no strong recommendation like this, but first try to find out her reproductive goals. If she is happy with this child, fine. Otherwise, if she really wants to have one more child, it's always better these kind of valvular lesion people finish their family as quickly as possible, because it is always a progressive lesion and they can get into problems in their future pregnancy if it is a lot of delay. Along with cardiac problems, they are also at risk for other preeclampsia, GDM, etc. The second thing is, in the inter-pregnancy period, the most ideal thing to undergo surgical intervention and correction. Here, I think this is moderate to severe kind of mitral stenosis. So she requires a surgical intervention that should be done in the inter-pregnancy period, and optimize her condition before pregnancy. And during that period, during the period of when she's planning pregnancy, a good contraception has to be advised. I think these are the things I want to stress on her planning for future pregnancy.
Yes, the rate of expulsion of PPIUCD is slightly higher than interval, but considering her heart disease, we should encourage her to have, because this is the most effective contraception for her. Of course, as sir said, small family norm, especially with severe heart disease, because they have to have a productive life. So it's better to have limit the family size. If they're happy with one, it's fine. Otherwise, as sir said, they have to plan it. When we choose contraception, we need to think two things. One is her cardiac condition, other one is the efficacy of the method and the side effects of those methods. LARCAS, the effective contraceptive methods on most of the conditions with cardiac conditions, so that should be utilized. As Kavita ma'am is not available, can I take the help of Dr. Sachireka, a cardiologist? What are the long-term plans for her from cardiac perspective, ma'am? So when do you want to reassess her after discharge? And does she require any interventional procedures? If so, like how?
I missed the initial slides, but I
think your audio is not clear, ma'am.
She has a moderate MS.
Dr. Hema Priya, ma'am is there online?
Yes, Dr. Shashireka is there. I think, ma'am, we can't hear you properly, Dr. Shashireka, cardiology. Ma'am, we can't hear you properly. Can Dr. Anil add something?
Just to add, as Dr. Srinivas Joyce sir was talking, time of cardiac reassessment should be done just before a discharge. That is what the protocol, even the ACC recommends, that this particular patient before discharging from the hospital should have to look into cardiology reference, then they should get discharged, and the regular interval at 3 weeks and again at 12 weeks, they need to revisit. As far as the interventional procedure for this patient is concerned, since this patient is moderate MS and her overall pregnancy was uneventful, including this particular birth, the delivery, and since she is asymptomatic completely, at present, this particular patient does not require an intervention procedure. However, this patient requires follow-up. In case it reduces, she becomes symptomatic, or meaning it can be done at an interval wise. It can be scheduled at a later stage after she finishes per curium period, which is always a high risk for the interventional procedure, and she can undergo, depending on the cardiologist advice, whether it's a favorable anatomy, they can go for balloon mitral valvotomy, or depending on the valve replacement, if it is not pliable. So now at present, it is not an emergency to undergo interventional procedure.
Yeah, she was discharged on positive day.
Can I comment?
Yes, ma'am, please.
Yeah, I agree with Dr. Anil. But for this particular patient, even though she was asymptomatic throughout the pregnancy and even during labor, that may not be the case when she have second pregnancy. So she needs to have an intervention before trying for the next pregnancy. And it should not be an immediate thing, because patient's cardiological condition may get worse during almost 3 to 6 months. So we have to plan according to the cardiologist later before she conceives the next pregnancy.
So she was discharged on postnatal day 6, and with the baby was fine with her. With the LARC, copper T was inserted, and then right now, Dr. Sunila, ma'am, can you just summarize the learning points from this case, ma'am? And what's your opinion about this?
All the senior experts in the panel covered all the aspects. I will just sum up what is done in our institute, which is a public sector hospital. It is a team-based approach, as everybody has mentioned, based on guidelines, and it is a coordinated effort. It's not like each one writes their own findings. We do get on one single platform and talk to each other, so it's a coordinated care, and it is a continued care, starting from the prenatal, antenatal, continued through the labor and postnatal and interconceptional period. So it is a continued care of the same team. And sometimes we do some training of the labor room staff based upon the requirements. So the training aspect is also there. Of course, good preconceptional and antenatal care decreases the risk during delivery. And most of the guidelines mention that a delivery plan has to be made around 20 to 30 weeks gestation. But in our institute, it's not so early as 20 weeks. Around 28 to 30 weeks, we do make a delivery plan. It is a detailed, individualized plan by the team, and it is documented. Of course, many times it is all surprises in obstetrics and cardiac. We do have to take care of the various surprises, and so different flow charts are maintained, and all these are accounted for in the plan. In our institute, we do a pre-anesthetic checkup for all cases at 36 weeks, both for epidural and in case she needs a cesarean section. Epidural is not for all, we don't do it for all laboring patients, but for severe cardiac diseases, we do advise the patients, of course, depending on the patient's choice, the cardiac status and all, we do plan an epidural. Infective endocarditis prophylaxis, of course, is as per the guidelines, not mandatory, in all cases, but in our institute, we do give our IE prophylaxis. And of course, vaginal delivery is preferred. Cesarean section is only when there is ejection fraction lower or aortic dilatation is more or is an impending infarction. Only in or other obstetric indication, because vaginal delivery has obviously less blood loss, less infection rate, less thrombotic risk, and also there's no acute shift of blood volume from the uteroplacental circulation to the maternal circulation compared to cesarean section. So we do prefer a vaginal delivery, and patients are monitored in the labor room or in the ICU setup. And postpartum, of course, there's increased risk of pulmonary edema. And during labor, we monitor with continuous fetal monitoring, and there's an ECG monitors and pulse oximeter, all the time. And in the first stage of labor, we put them in the upright position or in the lateral position, and we avoid putting them in the lithotomy position in the second stage as far as possible. And we cut short all our second stage labors, preferably with ventouse compared to forceps, because lithotomy position is required for forceps. Ventouse, we can just hang the legs down. So we prefer a ventouse. And we do give oxytocin. Nowadays, we can give 2 units oxytocin diluted up to 10 ml, give over a period of 10 minutes instead of an infusion, which shows less cardiac catastrophes compared to the infusions. So this also can be done as per the recent guidelines. We minimize prostaglandins, only if necessary we give. And PPICD, we do take care. We do many a times. And only thing is increased expulsion rate, which we explain to the patient. And it does come under the WHO MEC criteria too. So it can be safely given. And before discharge, we do have a cardiac review. And as Srinivas sir has already mentioned, repeat it at around 2 to 3 weeks, and then again at 12 weeks. So this sums up what we do in our institute.
Thank you, ma'am, for your inputs. Though she had an uneventful first delivery, and she was very compliant to her follow-up care, the pregnancy took a toll on her, and the cardiac disease got worsened in the interpregnancy interval, and she had to undergo valve replacement. She became pregnant after 3 years on anticoagulant. She was on acetone before conception, and then switched over to enoxaparin during the first trimester, back to warfarin in the second and third trimester. At 36 weeks, she was admitted for switching over to enoxaparin. So she also has stage 1 FGR. So the plan was to have planned induction of labor at 38 weeks. Liker was normal, Doppler was normal, no other concerns. Usha ma'am, how do we plan induction of labor when the woman is on low molecular weight heparin for prosthetic valve?
One little thing that I wanted to raise, switch over from warfarin to low molecular weight heparin in the first trimester. They have some new guidelines in which they say the requirement is less than 5 milligrams of acetone. Can it be continued safely? Can anybody add on that?
If the dose is less than 5 milligram, they can continue warfarin. That's what always the decision has to be. Yeah, the risk of anomaly.
Recommendation is if the warfarin dose is less than 5, the incidence of warfarin embryopathy is very less. So we can continue warfarin if it is less than 5 mg, and that is a recommendation. If it is more, then we switch over to the heparin throughout the pregnancy, which ideally would be low molecular weight heparin, because that's convenient to give. But some of the centers use IV heparin, admit the patient and give IV heparin during the first trimester, and then later switch over to low molecular weight heparin.
I'll add one more point.
To the patient. The choice is offered to the patient.
Yes. It should be bilateral decision from the cardiology, obstetrician, and the patient also has to be involved in the decision. We cannot decide this is best. That is because it's a joint decision from the patient, obstetrician, and cardiologist. So, but warfarin is less than 5 milligram, it can be continued. The information has to be given to the patient. We have enough information right now, so that can be given. So, when to stop low molecular weight heparin before induction, ma'am?
Yeah. So once you decided to induce a patient with a prosthetic valve, it's quite tricky. You're always on the verge of a scare that she might, the labor can be a little more prolonged and you can have a thrombus sitting there. The bridging might slip off. So these are quite tricky. It depends upon how we are going to induce the lady. I think this lady is a previous vaginal delivery. Am I right? Second pregnancy with the previous vaginal delivery. So we bring her INR down and probably about once, depends on how you're using. If you're using a balloon or if you're planning to put gel, it's going to take about 6 hours. So about 6 hours prior to you put it, you can stop it is what I would think. I would also take the cardiologist into concern before I take a decision on this.
If she's on low molecular weight heparin, preferably 24 hours before our elective induction, it should be stopped. If she's on therapeutic dose, ideally, ideal way of monitoring is the anti-10A level, which most of the centers may not have it, but at least 40 milligram BD is an option to give in those women. Dr. Shireka ma'am, can you please tell us, we know the pros and cons of unfractionated low molecular heparin in general, but peripartum, around the time of labor, what are the pros and cons? And do you want to give any other special instructions from cardiology perspective in this patient?
In any other case, when we use low molecular weight heparin, any other surgery, we would stop 12 hours before the planned surgery. But here in a prosthetic valve, it becomes more tricky. So better is to stop the low molecular weight heparin 12-24 hours, start on IV heparin, and then stop 6 hours before surgery. That is a better way of protecting the valve also. So these are the some measures that we can take, and then post surgery we can start low molecular weight heparin about 4 to 6 hours after the surgery, cesarean.
Okay.
Since the onset of labor is unpredictable when you're going to induce, that is pretty difficult.
That's the reason they say that unfractured heparin may be better, because it can be stopped 4 to 6 hours than to 12 hours. That may be an alternative. But when we give IV infusion, it has to be go on. That may be cumbersome for patient. So both has to be weighed, depends on the parity, Bishop score, and other clinical scenarios. So that's what really happens. We thought we'll induce at 38 weeks, but 2 days before her scheduled induction, she went into labor. Her last dose of enoxaparin was 8 hours before. So ideally, she's a candidate for epidural, but we know we can't give right now. The resident is trying to manage with the morphine as an alternative, but she's continuing to experience discomfort and requesting more pain relief. IV prophylaxis has been started. Anil sir, can we give effective alternative to epidural, like patient-controlled IV analgesia can be given, or we have to manage only with morphine, Atentanox?
Here, I think the alternative to epidural analgesia should include, as you said, the patient-controlled analgesia with the fentanyl, because fentanyl is almost 100 times more potent than morphine. And the side effects of morphine is like the fentanyl is not as pronounced as that of morphine. Whatever the side effect, including the respiratory depression and the patient's itching, whatever it is nausea, vomiting, everything is much less with fentanyl. That can be tried well. If there is no option for patient-controlled analgesia in that particular setup, the protocol does not allow, then probably a multimodal analgesia, including the non-pharmacological technique, whichever the institute is well versed with. And in first stage, we can take that. In the second stage, we can request the obstetrician to include the pudendal nerve block or the local infiltration into the episiotomy, including the non-anesthetic group of drug like paracetamol 6-hourly. Something like this combination could work in these group of patients. And with my experience, the one more thing, the alert thing, when in spite of morphine is not working in this particular group of patients, always be aware of the bladder filling and an abnormal position of the fetus. That is what, in my experience with labor anesthesia, what we observed. Just drain the bladder. Many times patient will be comfortable. The second, the abnormal position, the baby may be in an occipito-posterior position. That we have identified with our experience in particularly these group of patients, the parturient and labor. The second question was, do you have any specific
investigations require keeping, because she was on enoxaparin, suppose if she goes for emergency cesarean section, do you want to get any specific investigations?
Yeah, since it's an emergency cesarean section, we don't have time to ask any particular investigation. It looks like an emergency cesarean section. Just I want to relook into all the investigations available already done, like ECG, echo. You said ECG patient. No, you were not commented in this second scenario that whether the patient is in sinus rhythm. Echo, I just want to relook into whether how the function is, what is the valvular area now, any thrombosis, because we have stopped. And Dr. Shashireka was also talking about the low molecular heparin does not completely remove the risk of thrombosis in spite of using it. Though it reduces the risk, that completely does not obviate the risk of thrombosis. So I just want to look into those. Though these are all the static studies, we have acquainted with the skill of cardiac ultrasound. So the point of ultrasound, if the particular setup allows, that will be great in doing this. Then I will just look into the complete blood count, hemoglobin, and APTT is not available as the anti-factor 10A level is not available. And as such, we need to wait at least for 24 hours in this case if I want to go for regional techniques, because the patient is with BD dose of the low molecular heparin in this case. So that obviates almost for 24 hours, we cannot wait here, since my plan of anesthesia will change it to general anesthesia in this particular time. So as such, I don't look into any particular, and platelets is one more important. I wanted to comment with the previous question also. Always, whenever you use unfractionated heparin, we have seen incidences of the HIT, that is the heparin-induced thrombocytopenia. Though it may not be very common in pregnant women, but always we should keep aware of this, and looking into platelet may be a good idea, particularly in these cardiac patients. Then does she require invasive monitoring? In this particular case, no, I don't want to unnecessarily put an invasive monitoring. Suppose if this particular patient was associated with uncontrolled hypertension, or inaccurate NIBP, it is not correlating clinically, or if the patient was symptomatic, patient with NIHO class 3 or 4, or patient with a very low ejection fraction or a previous history of cardiomyopathy, or a severe MS. The same case with the severe MS, I would have gone for the intra-arterial line monitoring, or the central line monitoring for the inotropic or the anticipated vasopressor. Otherwise, in this particular case, no invasive monitoring.
Okay, vitals are important, including saturation, but invasive monitoring is only restricted for selective patients with high-risk cardiac disease, as Sir said. So though it's a second pregnancy, but she's complaining of pain and requesting cesarean section. So will it be beneficial, ma'am? Anjali, ma'am?
No, because she is already second gravida. The progress of labor will be very fast in these particular patients, especially they are heart disease patient. And when she has gone into labor, we can just accelerate with doing ARM and whatever analgesia Dr. Anil has told, we can manage that patient with all those analgesic things, and we can facilitate her normal labor because she will have less risk of having normal delivery than having cesarean section. Because in this particular patient, when she is still has taken LMW, her risk will be high, and we have to go for general anesthesia. So the risk for her is quite tremendous if we take her for cesarean section. So you just have to counsel her, because second gravida she will deliver, and with the first normal delivery, definitely she will have a good chance for the normal delivery.
So is there any cardiac condition specifically where you prefer to go for cesarean section?
Yeah, NYHA classification 3rd and 4th, there are indications for the cesarean section. Pulmonary hypertension is also, and if the person is decompensated during labor, is also again the indication for cesarean section. Severe aortic diseases are also another indication. Another thing is if she has a cardiac event in previous deliveries or any previous occasion, that also is an indication for cesarean section directly.
So otherwise, vaginal delivery is preferred. So
most of the patients, they will deliver vaginally. But nowadays scenario is changing so much, because I am practicing since last 35 years. And I know that I would have been told them to that the timing of delivery also once I assessed in active labor. But nowadays, no patient respond properly. So I don't know, cardiac patients specifically delivering normally, maybe a little bit task only. And I just wanted to add one more thing is regarding pre-anesthetic checkup. What I feel is any high-risk pregnancy, whether it is cardiac, whether it is severe anemia, whether it is obstetric reason like placenta accreta, whether it is severe PIH, or whether it is obesity itself, all these patients needs to have pre-anesthetic checkup, and you need to have a setup where you can manage it properly. Whether it is your own nursing home or whether it is your institution, you need to have all these things done prior to taking her for cesarean section or any delivery.
So with multimodal analgesia and one-to-one care, somehow she progressed to second stage. Now head is on perineum, but she's telling, please take my baby out. She's seeking help for taking the baby out. So Srinivas sir, which instrument do you prefer to cut short this active second stage? Anyone else want to take up this, ma'am? Usha ma'am or Sunila ma'am?
Hello, am I audible, madam?
Yes, sir, you are audible.
Yeah, sorry, I had muted myself. The issue with the two instruments, forceps and ventouse, in case of cardiac disease is regarding position and the patient's efforts. So, as the expert commented that they prefer ventouse delivery in all cases of cardiac disease because of the positional comfort, like it can be done in the lateral position or propped up position, etc. When we come to the forceps, the greatest advantage with forceps would be that you can avoid maternal efforts. The important thing that comes why we encourage cutting short of the second stage of labor in cardiac disease is to prevent maternal efforts. So personally, I would say I would prefer forceps rather than ventouse for instrumental deliveries.
So she had delivered with with forceps, and baby is fine. So when do you prefer to restart anticoagulants, and how do you do that?
Yeah, we usually start the restart because in this case particularly it's of very prime importance because she already has a valve replacement. So 4 to 6 hours we start with low molecular weight heparin around 40 milligrams roughly at around 6 hours, and after 24 hours she should be back to her therapeutic dose of low molecular weight heparin of 40 milligram BD. And here comes the concept of bridging thromboprophylaxis. So to take her back to warfarin, maybe the first two, we don't have a very clear-cut recommendation on how to bridge the thromboprophylaxis, but normally first 2 to 3 days low molecular weight heparin, and from the third day onwards you can overlap with warfarin a small dose 3 to 4 milligrams, and then by around 7th day low molecular weight heparin can be tapered and she can be on her previous dose of warfarin and she can continue the same thing. This is how the bridging thromboprophylaxis is planned.
Sashireka ma'am, do you have a different perspective? You want to restart warfarin within few days, or you want to wait for some time?
No, we usually restarted, the next day overlapping with low molecular weight heparin, provided there is no bleeding complications and the obstetrician is okay. And then we monitor the INR for its therapeutic value. It depends. This lady has got a prosthetic valve, so would want something around 2.5 to 3 the INR. And then once the INR is reached, we stop the low molecular weight heparin. We don't, individually it can take about 2 to 3 days to achieve this therapeutic INR. We don't mind starting the next day only.
So almost 14 hours of labor, she delivered a baby, and then the baby is fine, no PPH. 6 hours after delivery, when she was preparing to have dinner, she felt something uncomfortable and experienced chest tightness. By the time the resident arrived, she was already breathless. Resuscitative measures were initiated. There is an urgent call sent to cardiologist. What could be the probable clinical catastrophe, ma'am? And how do we manage her?
I think the most dreaded complication here would be a prosthetic valve thrombosis. That is the most dreaded complication here.
So how do we manage, like in this postpartum delivered no PPH? Is there a role for anticoagulant or go for thrombolysis or surgery?
If she is decompensating, I think we would prefer thrombolysis, because we have to save her. I mean, first an echo will confirm the thing. So, like, if you have done an echo, we can have the findings now.
Echo finding is not there. There's a small valve thrombus. Exact finding is not there. There's a small valve thrombus. Small valve thrombosis can be managed with low molecular weight heparin or an unfractionated heparin infusion, provided she's stable. It's only a small thrombosis. It can definitely manage conservatively. Thrombolysis would not be required. And once we see this valve thrombosis, we'll be a little more careful in monitoring her INR and overlapping with warfarin until we achieve a little higher INR as the target. Instead of keeping 2.5 to 3, we'll now move up the INR target to 3 to 3.5. And we also know that the postpartum period is the most thrombophilic period that we see. Most of our DVTs happen, most of our valve thrombosis happen during this time. So we'll be extra cautious and monitoring her more vigilantly during this time. So what's the long-term plan for her? You like to, when will you call her later? Do you want to redo surgery or no, you said it's a valve, it's a small valve thrombus. So if she settles with anticoagulation, nothing much is needed. But if she progresses and this valve thrombosis is going to increase, then she may need a redo surgery. So successfully she was managed with enoxaparin. Currently she's stable. The resident in the postnatal ward is sent to Dr. Anil for pre-anesthetic checkup as she was requesting tubectomy. So when do you prefer to do tubectomy in this these type of cases, puerperal or interval? What are the challenges you face, sir? Dr. Anil is online. I'm not able to see the screen section. No, if I can take this question. Yeah, sure, ma'am. Please. Because just now she is recovering from a thrombosis and we are going to keep a high INR. Personally, I would feel like you can just interval it, but I'll wait for the others' opinion too. Yeah, in this.
Otherwise, also, even she doesn't have.
No, am I audible?
Yes, sir.
Here, I lost my internet connection. Sorry for that. Here, my concern will be the balancing the risk of bleeding versus the valve thrombosis. Already, it has become a catastrophic. There is some event already occurred. So my take would be in this case is a typical situation where it requires a multidisciplinary, the pregnant heart team approach or the shared decision making. So in any complicated course like this, where the patient is already having a thrombus and very high risk for development of thromboembolic event, it is better to postpone for the interval tubectomy in this particular case. If we go, there is always a high risk because we need to prolong further the duration of without the anticoagulation free period in this particular case. If I want to go for surgery, again, the tubectomy once again being just now the patient has delivered, there will be so much of engorgement and the bleeding risk will become high. Now, on to the other side, because she is free, there is already thrombosis forming, that risk becomes high. So it is better to go for interval tubectomy in this particular case. Okay. Suppose if she hadn't had the catastrophic event. Once again, we need to, as a decision should be a multidisciplinary team approach. Once again, reassess the patient, see what is the risk of bleeding and thrombosis. If there is a risk of thrombosis is less, we can go for interval, the percutaneous tubectomy. Okay, so always it is a decision making in that particular situation with that particular patient and the heart team and the local facilities available.
Can I come in?
Yeah, sure, ma'am.
No, any patient with puerperium, it requires that hemodynamic changes will come down gradually. It won't be so sudden, is it not?
Right.
So is it recommended to do any surgery during that period? It is always should be in an interval. No?
Not always. It's again, as Dr. Anil said, it's a combined risk assessment.
Yeah, I know, because you are going to take a risk for that patient because still she is into the recovery phase of hemodynamic stability.
If she's talking
any patient, actually.
if she's tolerated well the labor and the hemodynamics during labor, and it may not be, we may not say no, it's not contraindicated. But if she had an even full course, then better to postpone to interpregnancy interval, because we have to see the other side of that. She may come back with one more. Yes, sir, please.
Also, it depends on type of valve. Most of the time, if patient is having, not in this situation, in general, the bioprosthetic valves, the risk of thrombosis is less. During that time, it is very good to go for peripheral tubectomies, unless subjecting the one. Otherwise, you're having a risk of subjecting the patient again at the interval period. Once again, they should be free of whatever the anticoagulation or the antiplatelet drug. Once again, the risk of this problems will reduce if the patient would have had a bioprosthetic valve. Unlike in this case, I think she's having mechanical valve.
But unfortunately, most of our patients have mechanical prosthetic valve.
That once again depends, because they are young patients, the longevity they should see. That's true.
I understand, if I may. But one thing is, see, we have stopped this prophylaxis 24 hours, even if it is elective. For her, we have, I think, 8 hours or something. Is it not? So puerperal will be not on the same day, is it not?
Yes. But
so we may have to start, again may have to stop. That the problem is there for everybody.
No, madam. We are changing from warfarin to heparin. Warfarin is the only definitive way of preventing anticoagulation. That is the best drug.
Yeah.
Because they have changed to low molecular heparin probably a week before.
I understood. Yeah, correct.
Okay.
So if I may just make a comment.
Yes, ma'am.
Yeah, so I think this is very different from the discussion that we're having, of course. But when we have had a chance to counsel her during pregnancy and even maybe sometimes before pregnancy also, I think it's a very good thing to also get the partner into the picture and tell him that it's much safer for him to undergo the permanent sterilization rather than the wife. So that would be one way of overcoming this problem.
We did counsel the partner for vasectomy. Unfortunately, it didn't happen.
Ultimately, she will come back with the pregnancy.
She came back in the interval period, had an interval sterilization, and she's doing well. So, ma'am, Gitanjali ma'am, can you give your opinion on this?
Yeah. So I would at the beginning try to be very happy and pleased that I'm part of this webinar, which is very fruitful for me especially. I work in the remote part of Karnataka, not a very good setup in most ways of how we should manage cardiac patients, and I have learned a lot through this webinar. So especially from this case, what I would tell other learning points are that before the intended delivery, we should switch from heparin to heparin from warfarin, because this has got a shorter interval after which the delivery would be safer. So maybe at 36 weeks, but of course, as already mentioned, we could have googlies and patients could go into deliveries, into labor at any time, and we should be prepared to handle that case. As in this patient also, she went 2 days before our intended planned date of induction of labor. And it was very well brought out in this case that low molecular weight heparin, the time interval which we have to stop for would be longer. And in case we are anticipating that labor could be not very predicted as to when exactly the patient could deliver, we could use unfractionated heparin, because we could stop it a little bit more conveniently. And thus, it could pose less risk to the patient in terms of thrombosis later on. Documenting the plan before the patient actually goes into labor. So this is something like, especially in institutes which have got multiple obstetricians taking care of the OPDs on different days of the week. So a patient comes on Monday, she sees a different obstetrician, and she comes back for a next visit on Wednesday. So this kind of thing should be avoided, and the same set of the team, the multidisciplinary team that we've always been speaking about, the same doctor should be catering to her, and there should be a documented plan as to what we have decided for the patient well in advance of actually when the patient presents in labor, which could happen to be not your OPD day. And so whoever is on floor also knows what exactly is to be done for this patient, considering her entire situation. As we saw, this patient actually went in for an event after the surgery, after the delivery. So restarting the anticoagulation in the postpartum period also is very, very important. And also to see that she doesn't remain undelivered long after her low molecular weight heparin had been stopped. That is very important. And we can use unfractionated heparin in this interval to see that we make better justice to her anticoagulation during the time of delivery. So anticipate PPH. We know that the patients are on anticoagulants. Arrange for components in advance, not only packed RBCs, but even the fresh frozen plasma, cryoprecipitated if available, and platelets also. And having a hematologist involved in the decision making and in how we actually do the transfusion practices would be much better for this patient. As already mentioned, restart 4 to 6 hours after delivery, after the risk assessment. And if the patient has received an epidural analgesia, then also consider how long after removal of the epidural catheter we want to restart the heparin. And always be aware, Srinivas sir brought up this 5-minute rule, which has been mentioned in Iron Donald, which is very important to see that we actually monitor the patient very, very intensely, even after the delivery, because she's got a lot of complications that we could still prevent and hopefully identify at the earliest, and be very watchful for a valve thrombosis. And again, as stressed in this entire webinar, multidisciplinary care involving all the specialists, including anesthesiologists, cardiologists, your intensive care, obstetricians, pediatricians, is very, very important. So, and in the intrapartum period, to keep assessing the need for low molecular weight heparin every 12 hours and unfractionated heparin. I personally do not have any experience with unfractionated heparin, but I think it would be something which we would introduce into our practice. And if you have planned an elective LSCS, then closer to 24 hours after LMVH. And again, don't prolong the period too much, again, to see that she should not suffer from a risk of thrombosis. So these are the learning points from this case.
Thank you, ma'am. So when we start induction, sometimes we start with mechanical methods and the induction goes on. Though we start 24 hours before the elective induction, in case the intrapartum is going to get prolonged, we can as well give low molecular heparin. It's not contraindicated because she should not be off from anticoagulant for a long period. That's the message. Though she was very compliant, she was on anticoagulant throughout the pregnancy, still she had valve thrombus. Fortunately, she was out of the danger. And so it's very important to keep assessing her the timing of delivery, not to be off anticoagulant for a long period of time.
And madam, if I could just add one more learning point, it is that we need to involve the husband also and counsel him for vasectomy, because his wife is at much more risk of the medical complications.
Yes, thank you, ma'am. So a lot of newer anticoagulants are there, but most of them are not safe during pregnancy and postpartum. So we need to know, because most of the time these women will be on various medications. A lot of other cardiac diseases are there, which as they mentioned in the beginning, the first session itself. But whatever the type of disease, the principles are the same. It only depends on the severity, except in few situations, vaginal delivery is preferred. So the take-home message is this multidisciplinary team management has come many times in everyone's slide that shows the importance of it. And we have to document the plan of management and should be decided well in advance. It should be disseminated clearly across various team members, because in a place where we have a different cadre of healthcare workers, it has to be taken from top to bottom. So it has to be documented clearly. Everything is important, from fluid, position, analgesia, antibiotics, everything is important. And the active second stage to be cut shorted. And we have to be extremely careful, because the increased risk of mortality happens around the peripartum period. And they might need to stay for a long period, the extended postpartum stay in hospital. And once we discharge also, we should have early postpartum visit, either through some way we should have that. It's not important that we manage this patient, manage the complications. She's out of danger. She has to have a quality life at least for a few decades to see her child living happily. So it's very important to have a long-term plan, sync with cardiologist with effective contraception. I thank every panelist who contributed to this panel discussion. Thank you, all of you, ma'am, sir. And thank you, Dr. Sushma, and also SMFMI chapter of Mysuru, for bringing me to Mysuru through this panel. Thank you so much.
Thank you.
Thank you very much, Dr. Shashireka, and very warm expression of gratitude to our experts, Dr. Sunila and Dr. Gitanjali, as well as to all the panelists. Now I request Dr. Anjali Sriharsha to propose to vote of thanks. Anjali?
Yeah, thank you. Thank you, Dr. Hema.
Respected senior colleagues and my dear friends, I extend my heartfelt gratitude to everyone present today for their unwavering support and active participation in our discussion on cardiac disease in pregnancy. Your presence underscores the importance of this critical health care, impacting the lives of countless women and their families. Firstly, I would like to thank our chief guest and also the guest of honor, Dr. Shanta Kumari ma'am and Vidya Tovi ma'am, for your time and your encouragement. And I would like to thank our esteemed speakers and panelists for their insightful presentation. Your expertise has deepened our understanding of the complexities surrounding cardiac disease during pregnancy, shedding light on the latest research, diagnostic advancements, and treatment protocols. Your dedication to this field is truly inspiring and invaluable. To the organizing committee, I thank you for your meticulous planning and coordination. Your hard work behind the scenes has ensured the smooth execution of this event, providing a platform for knowledge exchange and collaborative efforts. I also thank the MQ Pharma Inventia Division for organizing this webinar, especially Mr. Shrikant, Mr. Shivkumar, and Mr. Amit. And heartfelt thanks to Mr. Hardik for all your technical support. He's the head of the RX events. And thanks to all our delegates, your engagement and willingness to learn and share experience are crucial in fostering a supportive community. Together, we can continue to advocate for better healthcare policies and support system for pregnant women with cardiac conditions. Thank you once again for all your invaluable contributions and dedications. Thank you.
Thank you, Anjali. Indeed, it was an extremely very informative panel. Dr. Shashireka has taken maximum and special efforts to cover every aspect of the obstetric labor management, and it was really vast. And all the input from the cardiology aspect from Dr. Shashireka, Dr. Anil from the anesthesia perspective, and our own Anjali ma'am and Dr. Usha Rani and Dr. Sunila and also Dr. Gitanjali, all your insights and all your feedbacks are immensely very valuable. And of course, our today's CME has brought in a lot of insights and more information on the optimal management of this pregnancy in cardiac disease. And of course, we will continue our discussions in subsequent, we have one more webinar coming up on cardiac obstetrics as well as in another 2 to 3 weeks. And we wholeheartedly thank all the faculties and of course, all the delegates who have joined in. And it was truly very thoughtful of all our discussions. And of course, thank you everyone for joining and being part of this wonderful webinar.
Thank you.
Thank you.
Thank you, Dr. Shri.